For the benefit of the audience, we're just waiting for a couple more members to arrive. Since it's an executive session, we do need everyone present before we can proceed. So just give us a few more minutes. Good morning, everyone, and welcome to the House Committee on Health and Human Services and Elderly Affairs. As noticed, we have several bills to consider in executive session this morning. Before we get to those, however, I'd ask you to please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. A couple of the bills will be taking up.
Either one, 1669, I guess.
The first two bills that we'll be considering this morning, and we'll actually switch the order around a little bit and start off with HB 1669 FN, because they're both early bills. They both have to go to a second committee. I would point out to everyone here who may be making motions this morning and who will be responsible for the reports for the bills for which they make the motion, whatever that motion ends up being, and whatever passes, or whether it's no recommendation or whatever. I do need all the committee reports today, so we can get them in the calendar, and going forward, the Speaker's office has admonished all of the committee chairmen that all reports need to be done the day of the motions, and the executive sessions being held. So we have Representative Notter here from Leadership that will report back that I made that announcement, right, Representative Notter? You'll let the Speaker know I made that announcement? Okay, thank you. All right, thank you. So with that, I will open up the floor, and again, let's just reverse the order a little bit and start off with HB 1669 FN. And so Representative Merchant.
Thank you, Mr. Chairperson. I submit to the committee for their consideration Amendment 2024-0619H. I wanted to thank the...
I'll second that.
Oh, thank you.
Would you like to speak to your motion?
Thank you, Mr. Chairman. I'm a strong supporter of personal privacy. I think that's something we take dearly here in the state of New Hampshire. And I think what I'm trying to do is amend the bill for clarification. In working with both the Representative Leon and also the Department of Health and Human Services, I think this finds that sweet spot. Currently, the department does not share data within the registry now. So that's really not an issue. It's going forward, what do we do? Second, it changes the terminology from data to information. In talking with the department, I came across the fact that something called personally identifiable information, which is different than PHI, which is patient health information. Patient health information is defined by HIPAA. This is a terminology used a lot in cyberspace or into technology and so forth. So it's more broader, if you will, but it's clearer to what we're trying to accomplish. And thirdly, what I wanted to be sure of is that if a provider goes into the registry, whether it be a school nurse, practitioner, pharmacist, whoever go into the registry, that if they extract the information from the data to put it into their medical record on behalf of the patient, that is not included with restrictions. It becomes very difficult and onersome if you basically want to have every single provider who's ever taken anything out of the registry to have them go back and go through their records to remove it. So therefore, I want to be clear that this does not apply to a provider who takes information out of the registry. As far as the ability for the state when they go into any kind of sharing of information, we currently have the same situation with the prescription drug monitoring program. Our state law is very clear who can have access to that data. It's medical records, their prescription data. If the state wants to share that data with another state, they have to ensure that that state will abide by our state laws. And that, in fact, is what happens in that program as well. So whenever they have a contract with another state to share the data, that state has to comply with our state laws. So I think this is a sweet spot, is trying to find a way to protect privacy at the same time allow access.
Thank you. Representative Leon.
Thank you, Mr. Chairman, and thank you very much, Representative Merchant, for taking the lead on getting this amendment. I really appreciate everything that you do in order to value personal privacy and everything to support people here in the state, and I really thank you for your work on this. I'm going to support this, obviously, and I think this will be great to move forward and just make sure that we're removing a potential for concern from people and ensuring that our data will be handled correctly. So thank you.
Other discussion? Representative Shapiro.
Thank you, Mr. Chairman. I also appreciate the two representatives working on this together to get a compromise that hopefully we can support. I'm just curious, on the initial bill, there was a financial note of $3 million, and then that was amended and I believe this is the case, reduced to $160,000 to $180,000 for fiscal year 2025, and then $100,000. So I'm curious, with the amendment, is this fiscal note still likely accurate?
Thank you.
Representative Leon.
Sorry. Thank you. It should be accurate because this is just specifying that language. That was in order to have somebody work at the department in order to make sure that we do have the correct data entry sections. This is an ordinary bill, so it's headed off to finance. But we have removed that $3 million charge through both the prior amendment and this one. So I think it's been a good move.
You all set, Representative? Follow-up.
I would just, I'm going to vote for this because I appreciate the fact that people are working together to protect privacy. But I'm also aware of what was said on the floor last week about the limited amount of money that's going to be available for finance to appropriate for all these things that are coming forward. And this would likely not be my priority.
Representative Leon.
Thank you, Mr. Chairman. I recognize that we have limited funds because we are not sharing and we are not in the process of entering into any contracts at this point. I think that fiscal note is actually premature for spending in this year. Whenever we do look to agree to contracts in order to share that information in the future, there will be a cost to it. There may be, I assume that there will be this additional cost when we do make that choice and put this out for the contracts. But until we make that choice to share the data externally with other states or other bodies, then I don't expect that we'd be spending that money.
Thank you for that clarification.
Representative Merchant.
To follow up on Representative Leon, thank you for the question, Representative Shapiro. My understanding is because we're not currently sharing data, there's no change that has to occur within the department, so therefore there's no need for fiscal funds. However, if the department elects to share or want to share data with another state and therefore have to be sure that things are in place and so forth, at that point in time, it would require some fiscal funds to do it. So currently, based upon the way the amendment's written, there should be no impact financially to the state. However, if the department wanted to do something, they would have to come back and ask for the funds.
Other discussion? Seeing none? Okay, with that, a motion is ought to pass on Amendment 2024-0619H to House Bill 1669FN. I'll ask the clerk to call the roll.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel,
Yes.
Representative Nodder,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Priest,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
20-0.
Okay, great. Okay, do I have a motion on HB 1669 FN?
Yes, I'll make a motion to ought to pass as amended on House Bill 1669 FN.
Second.
Representative Leon seconds. Do either of you wish to speak to that motion? Does anyone wish to speak to that motion? Okay, when the clerk is ready, I'll ask him to call the roll. The motion is ought to pass as amended on HB 1669 FN.
Representative Land,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofalt,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel.
Oh.
Representative Nagel,
Not in the room.
okay.
Can't vote.
And Representative Nodder,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yeah.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham, Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Priest,
Yes.
Representative Tejas,
Yes.
Representative McDonald,
Yes.
20-0-1. I'm sorry, 19,
To 0.
0, and 1 not voting.
Mr. Chairman,
Yes, Representative Weber.
I'm wondering about consent. There's no appropriation to the bill, so, and it is going to finance, so.
There's no
my-
objection?
My hope is that it could go on consent.
Sure.
Especially as it's going to finance next.
Okay, yeah, if there's no objection. Christina, are we okay on that, or do you know?
No.
You don't, okay. You were giving me kind of a look back there, so I wasn't sure. Okay, if there's no objection, we'll put that on consent. Okay, next up is HB 1593 FN. Okay. Representative Shapiro, you have an amendment, I believe?
Yes, I do. Yes, I do. So I would move ought to pass, or I would move adopting amendment 0416 on House Bill 1593, and I'll pass it around.
Okay, I'll give it a moment to make it around before we get into any discussion. Do I have a second on that? Representative Weber seconds. And while it's making its way around, Representative Shapiro, would you like to speak to your motion?
Yes, so I hope everybody remembers how many people came to the hearing to testify about this. This bill concerns certain kinds of recreational activities that were previously paid for through a CMS waiver for developmentally disabled people. So these are activities that people do that are not like going to a therapeutic dance class for disabled people, but going to regular activities in the community to improve people's socialization and to improve people's integration into the community. And there was a great deal of support, and I think there was a great deal of support in this committee as well. So since the hearing, I've been working with Representative Leon and DHHS and somebody representing the area agencies. And what we have done with this amendment is, number one, we have reduced the original appropriation from $1 million to $500,000. We have also taken out making this a permanent fund. So this will not be a permanent fund. This will be a stopgap measure to fund these services until the next budget cycle, when this will be addressed in a more integrated way with other changes. Those are the two major changes that we've made. So This is a bill that the Department of Health and Human Services have been working with Attorney Namath, has supported. It's got to go to Finance Committee where it'll face the same hurdles as I was just talking about with the last bill, which is that there are limited funds and a lot of appropriations are heading there. But I think this is something that we can support that will support developmentally disabled people being able to have a full life in the community. And they've had it before. This was either a change in CMS rules or a new interpretation of CMS rules that made it so that all of a sudden they couldn't be paid for. So I would ask you to support adopting Amendment 0416.
Okay, thank you. Other discussion? Representative Leon.
Thank you, Mr. Chairman, and thank you, Representative Shapiro, for all the work you've put into this. I think that it's absolutely critical that we make sure that these services are restored, and I think that it's actually most important that we restore it first to those people who are already receiving these funds previously, because we already know that those people had these programs, they knew how to do it, they had already been vetted and approved through their area agencies. And so the idea of addressing them first and then handling anything else that will require a little bit more work to get those approved and get those paid for, I think would be a stronger path forward to make sure that we're restoring those funds as quickly as we possibly can. I think that it's been an absolute travesty that the way that this whole shakeup that came from the federal government has impacted this really important, really special community that we need to make sure that we are all supporting has been just terrible. But we also need to make sure that those people who are already receiving services are the ones who are first restored. So I really appreciate as far as Representative Shapiro came on this one, but I think that it's, I'll have another amendment to present that would then prioritize the people who missed that, who are already receiving services. So while I appreciate the work, it just doesn't go far enough for me. So thank you.
Representative Weber.
If we are going to be asked to consider the contents of another amendment as well as this amendment, would it be possible to have that passed out?
So I already passed that out, so I can change what I said. I simply don't think that this amendment goes far enough in order to ensure that we're restoring services. So I don't even need to reference it, regardless of whether or not that other amendment passes. I think the first thing we need to do is restore the services to the people who had them ripped away from them when the federal government made us change the way we provide these services. To me, that is the critical point. And I don't think that this amendment goes far enough. So I won't be supporting it. Thank you.
Representative Weber.
Understood. I'm just trying to work out for myself the order in which we're dealing with things, the ability to read what I haven't read yet, and decide whether I want to support the one or the other. Because while I appreciate your point, and I, in many ways, agree with it, I also am rendered very uncomfortable by saying that we're creating a two-tiered system here. And that's what it sounds like I'm hearing you saying. So I need to read the bills, the amendments, before I make a determination
And for
as to how I
clarification-
vote.
For clarification, it's 0633H, right, Representative Leon?
Correct. And that's the one I handed out before. It's 2 pages that are stapled together. If you open it up and turn to the second page, it basically just says that we prioritize. There has to be some way in which all of the cases are handled. Is it alphabetically? Is it by the date received? Or is it by the people who have already received these services?
Okay. Representative Shapiro.
I would like to speak to the two amendments, if I can.
I don't, really, we have a motion on the floor for one. I don't think we can consider the other at the same time. Representative Weber, you're the parliamentary expert here.
What we have done, what I used to do when I was chairing, was I would have them both handed out. I would discuss both of them before I'd take a motion. We have a motion. Committee procedure is very, very loose, as you know, and there are very few guidelines for it. I certainly have no objection, if nobody else does, if we allow reference to both while people are trying to make up their minds on the one before us. I don't see any better way of coming to a properly reasoned conclusion. So while it may not be, it just seems sensible to me that we should be able to consider and speak about the merits of both, because I think they both do have merit.
All right, proceed, Representative Shapiro.
Okay, so if you have both amendments in front of you, one is 0416, that's the amendment where there's a motion. And then there's 0633H, which is the amendment that Representative Leon has sponsored and has just discussed. And you take my word for it without reading it, they're exactly identical, except on page 2, lines 1 and 2 of Representative Leon's amendment, that line is added. The Department of Health and Human Service shall prioritize payment for services provided prior to July 1st, 2023, that were reduced or excluded from payment after such date. Other than that, they're identical. I have been working with the Department of Health and Human Services to make sure that we have everybody on board. So I was absolutely fine when Representative Leon's amendment was, when I saw Representative Leon's amendment. I don't think prioritization is necessary, but I don't think it makes any practical difference. I think there's enough money appropriated that anybody who deserves and, you know, it's clinically determined that they need these services will get them. So I don't think there's a practical difference. However, in working with the various parties, I was told by Attorney Namath at Department of Health and Human Services that they couldn't support that language. So therefore, I think that we should, and she is present if we want to hear from her. So therefore, my priority is, number one, to get as full a support as possible from this committee so that it go forth to Finance Committee where they'll look at it again. And that could be either amendment. But I think it makes sense for us to go to put this forward with an amendment that DHHS can support, because I think that in the long run, that will give us the best chance of it becoming statute and people getting these services. So those are the two distinctions. I don't know if we want to hear from Attorney Namath about what the particular issue is with those two lines or not. I will leave that up to the chair.
Representative Weber?
I would find it helpful if we could have a very brief statement from Attorney.
Attorney Namath?
Good morning, Mr. Chairman, members of the committee. For the record, my name is Melissa Nemeth. I'm an attorney with the Department of Health and Human Services. And there were a couple of concerns that the department had with the language added by Representative Leon in her amendment. And one is the reference to the date July 1st, 2023. That's factually incorrect, as there was a lot of work that was done with a corrective action plan that caused a lot of change to the developmental services system as of July 1st, 2023. This issue is completely independent of that. It is something that had come up throughout waiver amendments. And so that date just isn't correct. And so that is part of the concern the department had. And also based on the language that was received from CMS as to whether these services should be included in the waiver or not, and having this language here, the department feels that having language of this nature in a statute has the potential to have CMS take another look at this. And that could be the potential for some action on their part. Of course, no one knows if that would be taken or not, but the department just wanted to point those two items out for the committee's consideration. And again, as was stated at the previous hearing, the department is completely supportive of the concept of this bill and ensuring that folks, do have access to services.
Representative Leon.
Thank you, Mr. Chairman, and thank you for providing this. I'm sorry I wasn't able to meet up with you prior to discuss this, but I think it benefits the committee as a whole. Does CMS prevent the state from choosing how to spend state funds to support people here?
No, this would only be with respect to CMS only has a say with respect to those on the waiver.
So as a follow-up.
Follow-up.
And so as a follow-up, if CMS has no say about how we spend our state funds, why would spending state funds to cover something that the CMS has said is no longer coverable with CMS funds cause problems with us, with CMS?
So the risk is that the way in which these were provided previously, what the state has been told by CMS is that these were never supposed to be provided on the waiver, yet they were for a number of years. CMS has expressed a desire to look forward with the state, to look prospectively on fixing that rather than looking retroactively. And so the concern is references to there having had been continued payment on the waiver for these services. That's where the state sees there's a potential for action on the part of CMS. And as I said, there's no way to predict whether or not that would happen, but that's the concern.
Another follow-up?
As another follow-up, I recognize that concern, but I'm just trying to figure out if it's more important to restore these services to people who already had them first, or to worry about a potential question from CMS when they already know that we're moving forward and trying to get this done with state-only funds.
And something else I'd like to point out, this wasn't as if a curtain came down and everything stopped. These are being reviewed as people's service agreements are being reviewed. So it's being looked at kind of on a rolling basis. So as people's service agreements are coming up, if they had certain services in there before, when that's being renewed with their team, they're looking at it in the context of what the waiver permits now. And what CMS has said is allowable. So it wasn't, like I said, it wasn't as if a curtain came down and things stopped overnight. I know it probably feels that way to some people who were getting their services and went through the renewal process and maybe have been told those cannot be covered now. But I just wanted to provide that clarification too as to how this has been working.
Let other people ask some questions. I might have one after.
Representative Weber.
I actually have a comment rather than a question, so if anybody else has questions of
Representative Merchant,
Attorney.
you've been very patient over there.
Thank you, Mr. Chairperson. A question on the page 2, line 1. I'm concerned because if you look at the prior page, the department shall contract with one or more organizations. However, then we go back into page 2 on line 1, it will be the Department of Health and Human Services who shall prioritize the payments versus the organization who's been given the funds. I think it'd be problematic because we're getting into state not having the access to what was being done, yet we're requiring them to do the prioritization versus the organization that receives the funds. That's the first thing. Secondly, I do agree with the fact that many of these things probably happened after July 1, 2023, and therefore we get into looking at how we prioritize things. So I'm not opposed to prioritization. What I'm concerned about is the process we put in place to who's going to do the prioritization, because the way it's written today, the money goes to the organization, but then the department has to instruct the organization how to use the funds when they don't have probably a lot of the knowledge the agency has on how the funds were utilized. So it's just a quirk in the way it's written.
Representative Leon, did you want to respond, or?
Thank you. That's a good point. My question would be how the department plans to make sure that these services are first restored to those people who had them denied, and what your plan is moving forward if we authorize this without the language to make sure that the people who are already participating in this are the first ones who receive this money. So how would you plan to do that in the department?
I don't have the subject matter experts here with me today, and I wasn't prepared for that question, so I do apologize. But I think the department understands the question. And I know in the previous iterations there were, when it was proposed to be a longstanding fund, there was a whole provision about rulemaking. I think that would have addressed that. So I can see maybe potentially in the contract with the agency that would be administering this, that kind of language would be included. The department would include that with that vendor so that they knew, everyone kind of knew what the guidelines were for providing the services.
Representative Nagel and then Representative Weber.
Thank you, Mr. Chairman. Thanks for taking my question. When we originally saw this bill, the dollar figure was $1 million. Now it's $500,000. And I asked the question back then, do we know exactly what the total cost of what we're paying out now is? Do we know what that number is?
My understanding is no, that this is an estimation, and I think it was arrived at working with a representative from the area agencies who have the best knowledge about what is being paid out. And based on a survey of information that they gave back, this was based on that estimate.
Follow up?
So is that number sufficient to cover everybody or not, as was suggested earlier today?
The department's understanding is that based on the information the area agencies provided, that as to what was being paid out for these services, that this figure would be sufficient to cover those.
Representative Weber.
This isn't a question, it's a comment that I hope might get us farther forward. I'm remembering my French teacher whose favorite phrase was couper les cheveux en quatre, which means splitting a hair into 4 different parts. And it seems to me that, first of all, we're very much on the same page about what we want to do. And secondly, looking at it from the point of view of either of the 2 amendments, it sounds very much that as best we can determine, the people who have been receiving services could be covered by the $500,000 payment. It sounds further to me like if the department is having an agency administer, the department does simply put in the request for proposal or the directive or the contract or wherever it goes, because I'm not an expert on contracting, that concern. So I have been, speaking only for myself, I have been talked around into the proposal that I don't care which one of these 2 passes, and if the second of the 2 is the one that would get us to 20-0 rather than 10-10, which I think is a completely losing proposition on the floor of the New Hampshire House, and with the knowledge that it is still going to finance, where, as we all know, finance will do things to it that none of us intended or expected, and we'll have to deal with that at the time. I want to just state that I would be happy with going forward with either of these, and that's just one person's opinion. So,
Thank you. Representative Murphy.
Thank you, Mr. Chairman. Just a point of clarification from my notes I took. I thought that relative to the cost going from $1 million to $500,000, the people that administer the program thought that, given the fact that it would start halfway through the year, it would be probably only a quarter of that as well. So even just 250,000. But the other question I had is in Representative Leon's amendment, should on line 19 on page 1, should that be June of 2024? Because Representative Shapiro mentioned that these are identical, and that's only a difference in the date. So would that be 25 then? Or
Representative Leon.
Thank you. That's a great question. I actually wanted to make this effective immediately, and I didn't get the draft back that had an effective immediately date, because if we're able to get it through both bodies quickly and get it signed, let's not waste a month or a week or any time getting this money and getting these services restored. If I can ask.
Sure,
Okay.
go ahead.
So my other question is, I want to make sure that we prioritize this, but the language that I had was not correct. And we have a few other bills to exec. Would language along the lines of contracts to distribute these funds should require the agencies to first restore services before providing new services? Or something similar to that work, so that we can know that what we're trying to do is get people who already had something that was approved get them taken care of first, because there's time and resource constraints on everything. If we already know that, the gentleman who is in the bowling league, the people who are already receiving these services, we already know it's helping. So if we can make sure that that happens first before we have the resources to figure out anybody who didn't have them before, I think that that would be the most equitable one, because it's not going to take much work to reapprove what had already been paid, but it will take time for people who are establishing these programs. Could there be language about that?
I think there probably could be, and if there is some direction to the department. I think what's difficult is these are coming up as service agreements are being renewed. So I don't know if there is the area agency experts aren't here today, but I think the department would need to turn to them to say because if the department doesn't know, if new budget requests are coming in and they don't have that, the department wouldn't necessarily know, oh, this individual had this before and now they don't have that in their budget. So I don't know if there's a good way to gauge that. And the agencies have also been turning to their family support councils in some instances, who have authority. They make up their, they have some rules they have to abide by, but they have policies and guidelines, so that for some people that were getting the service, it was in their service agreement, it wasn't approved when it was renewed. They've gone to their family support council seeking this funding, and in many instances, it's the department's understanding that the family support councils have approved that. So for some folks, there is a mechanism for which they have had some continuity, but it's difficult to know. I don't know that there's a exact metric to understand who had what and when and what has changed. But I think the department would certainly be amenable to trying to work through that, and see what can be done.
Representative Merchant, then Representative Shapiro.
Thank you, Mr. Chair. I offer to the committee the following language. The Department of Health and Human Services shall include language in the contract with the organization for that organization to prioritize services provided prior to July 1st, 2023.
Representative Leon.
I think that's almost there. It sounds like the July 1st, 2023, but to provide services previously offered due to a service reconsideration. Previously, what would be the better thing instead of the July 1st, 2023?
And maybe I'm trying to think on the fly here, so pardon me, but maybe in the individualized budget, that is what authorizes the payment for services. So maybe if it was in someone's individualized budget previously.
So previously included in an individualized budget? Is that close enough to get it to finance?
I know, like I said, the department supports either, and the department's intention was not to, was to provide information so that people were aware, and that if the department were to raise concerns in a further committee, by full transparency, did not want folks to say, well, why didn't you raise that concern earlier? So that was the department's intention in bringing any concerns forward.
Representative Shapiro.
Yes, I just want to remind people that Representative Stringham, who is sitting in the back of the room, and Representative Edwards, who came in to inquire about this bill earlier, are the two sponsors of this bill, and they are both on Finance 3. And it will get a kind of a very thorough going over when it gets there. So I think we can make a decision about which amendment to use and move forward.
Representative Weber.
I'm still in the cutting the hair in four part. I think that what Representative Leon's amendment does is express pretty clearly what, takes care of a lot of the concerns that people had. And while I would prefer the language of the other one, I think that this does give a sense that what we're trying to do is fill the gap first, and then if there's any splash over, that's great. And we've been assured that this probably is okay. The other thing I want to remind people, and I'm thinking of Representative McMahon and saying, while we're still young, is that this is a temporary fill for something which is now just going to be a temporary till the end of this budget cycle, and then should be addressed more comprehensively going forward by the department in the next budget request. And we hope that they've heard very clearly our concerns about the need. But my suggestion would be that perhaps this amendment could be withdrawn and the other amendment could be offered. We could vote on it and send it to finance, where there could be further refinements if necessary.
Your suggestion, Representative Weber, is to withdraw the motion and the second on 0416H? Is that what your suggestion is, or?
I'm speaking only personally,
No, I understand.
so.
Representative Leon.
Thank you, Mr. Chairman. We do have several other bills in front of us, and I did want to make this effective upon passage. The language that Representative Merchant suggested, the Department of Health and Human Services shall include language in the contracts with the service providers to prioritize services previously included in individualized budgets. And changing it to effective upon passage shouldn't take long from OLS. So if we can withdraw the motion and then move to another as soon as it's printed, I think we've already had a lot of our discussion, and then we'd be able to move forward. I can send that along right now with both of our names, Representative Merchant. Okay. And would you like to be on there as well, Representative Shapiro?
Yes, sure.
Okay.
And I will agree to withdraw my motion to adopt.
Okay, and who made the second? Okay. Okay, so,
Excuse me, Representative McDonald, is it possible to add one more clarification to what Representative Leon just referenced in the proposed amendment? I think you said contract with service providers. Is it really meant to be the contract that is in section 4 of the proposed bill?
Yes, it is. So should
Okay.
I just say in the contracts to prioritize service, or should I use the language from section 4?
Or I'm wondering if just referring back to section 4, so it's clear which contractors. The way you had worded it gave me pause to think that people might think it was a contract with any service provider rather than what was for administering these funds.
Thank you, and that's why we're woodshedding this right now. So include language, let's see. And then that would be in the contracts designated in subparagraph 4.
I believe that would get the committee to where they were looking to get.
Thank you.
okay, so the motion has been withdrawn and the second has been withdrawn. If I'm understanding the sense of the committee, we'll move on to the next bill, and we'll come back to 1593 shortly. It is an early bill, so we do need to take action today. Okay, so pending the amendment coming from OLS, we'll move on to HB 1393.
And just before we move
Sorry,
on, Mr. Chairman,
Representative
if I may, our researcher has asked us that if it is at all possible, given the sense.
I'm sending it right now. Okay, good. Yeah, I'm sending it right in. Okay, I'm about to send it over with our names.
I was just going to say that the sidebar that I had was possibly could the report be written while we're attending the arrival of the amendment so that the report can be given and sent in.
Yes, I actually have already I've already drafted a report, so I was trying to think ahead on that one.
Yep,
So I already
good.
have language, and I'll make sure it's accurate and correct.
And actually, if we could be doing the same thing with 1669, Representative Merchant, you're doing that one, right? New time, right? New time, I don't think it can be done too soon, but noontime is acceptable, I guess.
Yeah.
Okay, anything else on HB 1593 FN? Okay, we'll revisit that shortly. HB 1393, do I have a motion? Representative Nagel.
I'd like to make a motion that this HB 1393 is an expedient to legislate.
Okay, is there a second?
I can second that. Or sorry, Representative Weber wants to second.
Representative Weber seconds. Representative Nagel, do you wish to speak to your motion?
Yes, this is very spontaneous, but I will do my best. I'm actually on the State Health Assessment and Initiative Committee. We actually had a very long sidebar discussion on this particular bill earlier, just the other day. it's a very complex process to create that assessment and that initiative, and there's an awful lot of priorities that we need to have a fair amount of, I hate to use the word wiggle room, but wiggle room to decide what are priorities. This is obviously a really important issue, but there's also a lot of other issues, and I think to place this in statute at or above other things is inappropriate, and I think we need to let that committee decide what the priorities are, and I already know that this is a priority.
Representative Weber.
Thank you, and thank you, Representative Nagel. I agree, and the outcome, if we were to put it in statute, would be that next year this committee would have 47 or 78 or 132 other equally concerning conditions that we would be trying to insert in statute. And the point of the plan is a balance. The point, and I think that if in writing the report writer could include both how important the committee members think this issue is, and that the issue has been brought up in front of the commissions, that's the appropriate commission, and it's being taken into consideration. And I'd be glad to work with you on that if that's helpful later. But I think that if the report states those things, it sort of clarifies the intent of the committee. This is not a dismissal, it's a referral to the appropriate place and a statement that action has started to be taken and is to be ongoing.
Representative Nagel.
Yeah, if I could just add a follow-up to this, if you've got nothing better to do, I suggest you look at the website for this program. It's not about individual diagnoses. It's about looking at the whole person in 4 different categories. So I would add a factor of 10 to the potential priority list that we could be dealing with. But I appreciate that statement.
Any other discussion? Okay, if not, I'll ask the clerk to call the roll. The motion is ITL on HB 1393.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel,
Yes.
Representative Nodder,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham, Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Priest,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes,
20-0.
there's no objection. We'll put that on the consent calendar. Okay, next up is HB 1581. Do I have a motion? Sure, Representative Nagel? I need a committee report, yes. Sooner the better. This morning, noontime, shortly thereafter. It's not an early bill, but I would like it today. Okay.
1581.
Moving on to HB 1581, Representative Leon.
I'd move ought to pass.
Motion is ought to pass. Is there a second?
I'll second it.
Who said that? Representative McLean? Representative McLean seconds. Representative Leon, do you want to speak to your motion?
Yes, thank you, Mr. Chairman. We heard a lot about the different characteristics of cannabis, whether it's grown under lights or under natural light. Just like anything else, inputs matter. Just like if you have a strip soil or a very rich living soil, you're going to get a different product. I believe that allowing them to operate an additional cultivation location will help them to make sure that they can have the supply that's necessary. And allowing this to be a greenhouse, I think, brings beneficial, brings a lot of benefits to us. All of these are going to have to comply with local zoning laws, so we're not stepping on any local control. We're just giving enabling legislation to allow more options for the cultivation. And especially given that the whole landscape may be shifting moving forward if adult use cannabis does become a factor, the more that we can ensure that the quality of product and the richness of product in the therapeutic cannabis is able to take advantage of all the benefits of natural sunlight and everything else in order to be the best match for people who need cannabis as medicine as opposed to cannabis as something else, that I think that that's going to benefit them and help to keep this program viable. Because in other states, when there's been adult use legalization, in Vermont, the amount of people using the therapeutic program actually cut in half because there were a lot of people who were happy with an off-the-shelf option. So the more that we can support the vibrancy and offerings of the alternative treatment centers to best meet the needs of patients, not recreational people, I think that this is good and this is moving things forward in the state.
Other discussion, Representative Nagel.
Thank you, Mr. Chairman. As the proud number one of a 19-1 vote on a somewhat similar bill, but quite different, I actually support this bill. I like it that it's under the setting of people that we know really know what they are doing. I've been to these centers. I see what they do. I know how smart they are. They're PhDs in horticulture. They're amazing people. And I think this is a great solution for a very, very difficult problem because these ATCs, I think, are struggling a lot more than we think they are.
Other discussion, Representative McLean.
Yeah, thank you, Mr. Chair. I mean, I think, we're almost 10 years in with this program. There were a lot of security concerns up front before we knew a lot. We've had an opportunity to see how those are manifested in other states such as Maine. So I don't think there's a real deep concern on the security side, but also from the perspective of cost. While we have a very good product in New Hampshire, cost-wise, we're not as competitive. And so setting up an operation that will help drive down the cost, it makes it competitive and drives people towards the legal market. So I hope that helps with harm reduction and other things. So I think this is a good bill.
Representative Missouri.
Thank you, Mr. Chair. I'm struggling with this one, honestly. And I put in my notes, and I remember it from the hearing, is that the analysis, the word second, kind of contradicts the word being used in the actual bill language of additional. The word second is very different to the word additional. And so that was my concern then, and I do recall law enforcement letting us know that they were not in favor of this because of how it would be hard to manage for them. So I'm honestly struggling with this one, just full transparency. But those are my two concerns with it.
Okay, thank you. Other discussion? Okay, seeing none, I'll ask the clerk to call the roll. The motion is ought to pass on HB 1581.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, no. Representative Kofalt,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
No.
Representative Nagel,
Yes.
Representative Notter,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham, Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Priest,
Yes.
Representative Tejas,
Yes.
Representative McDonald,
Yes.
18-2. And I'm fine with consent.
Okay, any objection if we put on the consent calendar? Okay,
And Mr. Chairman, did I miss on 1393? Did we put that one on the consent calendar because it was 20-0?
Yes, we did.
Okay, I missed that. Thank you.
Okay, next up is HB 1706 FN, and I understand there may be an amendment to that.
Yes, Representative Phillips is bringing this one around. With this, I think we need to take a look at it and see where we are. If we're not fully satisfied with what we have, let's get some constructive comments and see what we need, and figure out how to move forward with this if that's the will of the committee.
Okay, we'll take a look at the amendment. Is it,
Exactly, and I
What?
apologize for speaking before being recognized and before we had the bill in front of us. Wasn't
which
meaning to
bill?
jump the gun.
Which bill?
1706?
Thank you.
Thank you.
Oh, she hasn't actually made a motion yet.
Actually, and if you'd like, I can move amendment, and I'll tell you the number in just a second. Amendment 2024-0577H.
Is there a second?
Second.
Representative Cushman seconds.
And as it gets around, we'll let everybody take a look. And then my question would be to the chairman. The prime sponsor of the bill had worked on this amendment, and the question would be if we would want her to walk us through what changes were made so that we can understand, because this was a pretty big change in the bill. So I defer to the chairman on that.
Okay. Get the amendment fully around and give people a moment, and then Representative Phillips will be welcome to come to the witness table.
Question, Mr. Chair.
Yes, Representative King.
Is it normal that we would ever be given just like 5 minutes time to just silently read something? Because sometimes when somebody's speaking, you want to listen to them, but you also want to read it for yourself. And I can't do both at the same time. So is that normal to do that, something like that?
It's case by case. There's no formal procedure on that, but if we want a 3 minutes to read this through first. And,
I would second his
Oh, okay, sure.
motion.
Sure. Yeah, let's take a moment to read this through, and then let me know when you're ready, and then we'll ask Representative Phillips to come forward. How does that work? Is it amenable to everybody?
Yep.
How's everybody doing? Anybody who needs more time or? No, no, go ahead. If you need some more time, go ahead. Also, Representative? Okay, Representative Phillips, if you'd like to walk us through this amendment?
Thank you all for this and for reading the amendment. Representative Emily Phillips, Rockingham 7, Fremont, New Hampshire. So I went back and I watched the, 2.5 hours on this hearing, and I took in all of the feedback, and I just heard a lot that the original bill was overwhelming, a little bit redundant. So I trimmed down basically the original bill. I'm not sure if you have copies of the original one. It's probably hard to determine what was cut, but everything that was removed from the original bill, I can go through what was changed, but the only thing that was added was one condition that is a complication. So I have my Google Doc that I sent. The major changes was the original bill asked to show parents considering a circumcision the restraint board and some tools used for the procedure, and instead we switched it out with an image of, so that the providers didn't have to re-sanitize a restraint board or have one dedicated just to show parents prior to the procedure. I removed no healthcare provider shall solicit any parent for circumcision procedure. That was originally in there. There was a 25-year clause asking the hospitals to hold on to the original consent form for 25 years. I removed that. From what I'm hearing, EMR records are forever, so that was unnecessary. I removed a sentence that said, since it's a normal physiological condition for boys to have non-retractable foreskin prior to puberty and often until late teenage years, healthcare providers shall not use a diagnosis of phimosis in order to solicit a circumcision. I changed circumcision is associated with between 20 and 47 known complications. I took that out and just said many, because who's going to argue how many known complications there are? I added in buried penis syndrome into a reason. I'm sorry, a injury after a circumcision or a condition that can be caused by circumcision. Buried penis syndrome's in there. I took out the statement, which I felt was personal. Your son may want an intact penis, and decision to have a circumcision denies him his body integrity and autonomy, which he may resent when he matures. I took that out because obviously it's already kind of suggesting that this is not medically necessary. I took out the section, there was a large section that said there is no proven medical benefits following newborn circumcision, because I think that is disputed, that there may be a small medical, I'm not sure. So I took all that out because it was just carry on and redundant. The actual medical need for circumcision in adults is as low as 6 in 100,000, I guess. Again, you can't put in statistics there because it could change over time, right? Took out the non-surgical options for alternative prophylaxis and treatment of potential problems are those that are tissue sparing. Receiving this consent form does not mean the circumcision is recommended. Parents may freely choose to not circumcise their son by withholding signature and returning the form unsigned. That's redundant, so I took that out. And then I took out the other section, lastly, that said, prior to approving circumcision, consent forms, and intact care guides, the department shall provide copies of such forms at no cost to registered nonprofit advocacy organizations. Again, we took that out. That was redundant. And then I changed the effective date from 60 days to January 1st, 2025, because I'm assuming this is going to take some time to get everybody on board. So that's the gist. I mean, I know it's a lot to talk about and consider, but I think that it was overwhelmingly clear that informed consent is not happening consistently and that people want it in New Hampshire. So thank you for your time and consideration of the amendment.
Representative Seth King.
Thank you, Mr. Chair. Thank you for taking questions and doing all this work. Maybe I missed it. On line 22, you have section F there, solicitation, the definition. But I'm not seeing any corresponding language in the bill regarding solicitation. What's the point of having the definition if it's not later referred to, or is it referred to and I just missed it?
That's a great catch because I did remove that, but yeah.
Okay.
I see another hand up. Representative Shapiro, did you have your hand up?
That was the identical question that I was going to ask.
Okay, two minds of the same direction. Other questions? Representative Seth King again.
I'm not sure if this question should be directed to the one testifying or the committee in general, but I'm just curious, maybe the doctors in the House can help me understand this. Is it normal to put informed consent language in statute? And if not, when we do have informed consent mandates, who do we trust to write the informed consent language when it's mandated? So we put a mandate, something needs to be informed consent. Who are we trusting to write that language if it's not in the statute? Thank you.
Representative Nagel.
Since I just got handed 15 different informed consents that I've written in the past that I need to re-review and have back to our institution in the next 3 days, I feel very compelled to answer that question. I've written dozens of informed consents in my career. Historically, way back when I started, it was just me. I did it, but nowadays you have to go through an institutional review group. They have to okay it, make sure it's legally acceptable, things like that. To actually put an informed consent of this type in statute doesn't happen. This would be extremely unique, and I'll leave my comments on that practice for later.
Representative Cushman.
Thank you, Mr. Chairman. There are some informed consent requirements that I've come across in statutes and administrative rules, particularly the one that stands out to me now, but I know that I've seen others, are the requirement for vaginal births after cesarean section in the midwifery rules. So there are some, but they do, they defer to the department to make the form. So the department does create the form just like this one. And their guidelines, they defer, basically the provider gives a information sheet that's written by the New England Quality Neonatal Network, I think is what it's called. Probably butchered it, but they give the fact sheet that an organization creates, and then the department has the consent form that is printed and the patient has to sign and is returned.
Representative Weber and then Representative Nagel.
I was just going to point out the difference between being in statute and being in rules. The statutes are created by us lawmakers, and yes, we have a few docs and we have some advanced practice nurse practitioners and some other people with very good qualifications. But most of us don't have any of those qualifications. And the point of rulemaking is to delegate to those people who have significantly more knowledge the creation of forms that might be that need specialized knowledge in order to create them. However, that said, I still have a problem with the actual drafting of the language of a consent form, the specific language, because things change. And sometimes it's quicker to change a statute than it is to change a rule. If the legislature has guidelines, then that's one thing. But to actually put specific language in any case, I think for me is a deal breaker. At least I haven't seen one yet that I would agree was the right way to go.
Representative Nagel and then Representative Leon.
Thank you, Mr. Chairman. You pretty much said almost everything I wanted to say. The only thing that I would add, as part of being in this job, I had the very unpleasant job of looking through most of the medical rules. And I'm not aware that there's any informed consent specifically in the medical Board of Medicine rules. What they do refer to is to the AMA Guide of Ethics as to how you create and the requirement that you do use an informed consent.
Representative Leon and then Representative Merchant.
As well. Thank you, Mr. Chairman. I think informed consent actually is a really important core part of this decision. There's two different methods of informed consent. There's provider-centric informed consent, where you need to tell the person what a provider thinks they need to know. Then there's patient-centric informed consent, where you need to tell the person what the patient wants to know. Sometimes those aren't the same. And it's actually a really, really big difference because we're moving towards sort of a more homogenized medical system, one where there's more focus on herd management than individuals, and that's an actual term. So I'm not trying to be rude by saying that, but that's actually one of the terms that's used in some of the literature. And as you move away from a patient-specific informed consent, if there is more of a standardization and a deference to experts, there's a really big chance that people in the state will be harmed. I think that it's actually really important for us to try and work forward towards this. We probably can talk some more, but I'd be willing to withdraw my motion of the amendment and then maybe suggest that anybody who wants to work on it, I'd be happy to talk to people. We can figure out if it should be a subcommittee or if I should sort of do this ad hoc with people. But I think that patient-centric informed consent, especially for something like this, is key. I was in the room with all three of my sons. I have a feeling that may not have been three if my husband had been in the room. So, thank you.
Representative Merchant and then Representative Murphy.
Thank you, Mr. Chairman. There's a couple of concerns I have with the amendment. If you go to page 2 on line 24, it talks about a religious circumcision in a non-medical facility. Many times you may have a person doing a religious ceremony inside of the medical facility, so that could occur, and right now that would not be allowed. You could have the rabbi go into the hospital to do it there versus doing it outside of the facility. So that's a concern I have. Number 2, on line 25, page 2, the department has no jurisdiction over a licensee. That's the Board of Medicine, the Board of Pharmacy, the Board of Nursing. They're the ones that have the jurisdiction over that license, not the department themselves. Number 3, if you look at lines 16 through 22, if you have a situation where you have two parents in two different households, known as a divorce, who rules? Because you could have one parent who wants to do it, has physical custody of the child in medical care of that child, but the other parent, for whatever reason, opposes it, just to be what, if you will. That is not dealt with here. That means you have to go to the court and try to figure out who has jurisdiction over this, which is a problem. Number 3 or 4, I do think that it's important that the parents have the appropriate education, not the consent form. It's the education that's critical here, not so much that they sign a consent form. So I'd be more than glad to work with Representative Leon to try to find ways to thread the needle to achieve what we're trying to achieve, that parents, first and foremost, have the knowledge to make the appropriate decision. And also, if you look at on the page, most of what's here is all about the risk, and it's very negatively written. And when you get into the consent form, if I was to read something like that, I'll tell you, if you read the package insert in a drug, you would never take another one in your entire life. That's why we have medical providers to help us understand what language is that's put into the package insert for a drug. This is kind of the same thing, where all of a sudden you have a situation where you hear all the negative things about whatever it is and nothing about the positive side. So I think for those reasons, it needs to be amended. I think we need to work on it collectively, and I'd be more than glad, not more than glad, I'd be willing. I'm running too many things now, but I'll be willing to work with Representative Leon or anyone else on the committee, Mr. Chairman, to try to find a way to thread the needle.
Representative Murphy and then Representative Nagel.
Thank you, Mr. Chairman. I'm not sure we're in the ask the presenter questions yet or just discuss the
No, go
bill,
ahead.
but I wasn't going to ask a question. I was going to make a comment more than anything else. And I would say that over the last 40 plus years, I have probably obtained over 10,000, at least 10,000 consents. I would say in that period of time, I've probably used over 10 or so different consent forms, and every one of them was a generic form. Informed consent between a provider or surgeon, or even if you're given an injection in the office, is between the provider, surgeon in my case, with the patient. It's a conversation. It's probably the only conversation that really keeps you out of the courtroom if something goes wrong. So I totally and fully embrace the concept of informed consent. I think that put in any language in a statute or into rules, especially if you try to make up a specific surgical consent for every procedure that we do, is going to be terribly problematic. It's a very dynamic, process, informed consent. Things change, as I said before. I used over 10 different consent forms in my career, and over 10,000, I'm sure, that I've gotten myself. I find it hard to imagine why, in this procedure specifically, we would want to actually have to show them images of tools that we use, or even bring the tools in. Certainly, it's an improvement to show an image, but certainly it's terribly problematic to even do that. And the reason I say that, having done a number of procedures over decades, these procedures change oftentimes. And if you were to do, say, a total knee replacement or total hip, the instruments that we use change dramatically. The implants that we use change dramatically. And to put in the question, to put into statute or into any of these informed consents, images showing the tools that we use, I would find that I would probably say that the majority, or not the majority, a large number of patients who would otherwise benefit tremendously from a joint arthroplasty, meaning replacement, would be scared to death if I showed them the instruments that we use that look like they come from a hardware store. So, drills, saws, cement, glue, prostheses that we use, the weight of the prostheses that we use. These are all incredibly difficult to show a patient and then get really a truly informed consent. So I have a very hard time understanding at all putting informed consent language into statute or into rules because of the dynamics of it, because of the complexity of informed consent, and because it is probably something that we do and we take as a very important part of our conversation with any patient to try to inform them as best we can. Because I can guarantee you that in all the informed consents I got, I could never, ever have included comprehensively every potential risk or benefit that they may perceive that they have or that they encountered during a procedure. So I would find this terribly problematic in any way, shape, or form to do this, especially the informed consent part of it. Thank you.
Thank you. Representative Nagel and then Representative Weber.
Thank you, Mr. Chairman. I'm just going to be blunt and say that there is no way I would support the amendment or the bill. With that said, what they did that was really important was bring up this whole notion of informed consent. I really appreciate the discussion that Representative Merchant and Representative Leon have come up, and I do want to point out the whole concept of informed consent and the doctor-patient relationship has changed dramatically in my 35 years and your 40 years. When we started, it was basically, we dictated to the patient what he did, and they did it without question. It's not like that anymore. We use a mutual consent participation model now. And what's really scary, fun, and everything at the same time is I swear patients come in now and they know more about what I'm doing than I do. And our discussions have gone from me informing them as to risks and benefits to me discussing information and misinformation on what they know. And it's, to me, that's really exciting, but it's the way things are right now. And I think that we need to seriously sit down as a group, and I'm not sure this legislation is the right way to do it, but I think we really do need to sit down, have a vehicle, and talk about where we're going with informed consents in the future. Because I don't disagree with their point that it's flawed right now, and I think we can make it a lot better, but I don't think that this legislation for a specific thing is the right way to do it. And with that said, I have 3 pages of talking points of my concerns about this bill, so I don't want to bore you with that, but I do think that that suggestion was an incredibly good one.
Representative Weber.
I was going to just say that I think the one thing that I talk about people who know a little bit about everything and come and tell docs about it. But the thing that I was really interested to learn recently in a conversation about this bill is, of course, something that had not occurred to me. I'm not a parent, so I haven't done any of this stuff. But the OBGYN, who is the person who is treating the mom through her pregnancy, is often not the person who is doing the surgery on the infant, and it is the surgeon doing the surgery on the infant who must obtain the informed consent. Because I was thinking, we just need to make people focus on talking about this earlier, which I think is a concept that all of us kind of grasp. So I too come down on the side of, first of all, I find a lot of the language in here bordering on offensive, but I also acknowledge the need for education and the need for dialogue and the need for more emphasis on the informed part of the phrase informed consent. So that having been said, I don't have any problem with people working on something that's going to be about education, but if we're going to be about consent forms or specifics about consent, that's going to be a hard no for me, just so I don't have anybody losing time over it. And the more I listen to the discussion here, the more I wonder if this bill might not be a vehicle for a true interim study to talk about the consent issues that I think all of us recognize are very real and needing to be addressed. So I just throw that out there as a thought.
Representative McLean and then Representative Shapiro.
Yeah, thank you, Mr. Chair. And, I have enormous respect for the doctors on this committee and the fact that it is very difficult to put specific language into law. And I kind of support that sentiment. But the concern I have was that the testimony being given during the public hearing was so compelling that you have people who had just given birth who are having a form. That form should have been presented to them weeks before. So maybe the solution is not to put it into statute, but the existing system, it's not just about what's in the form, it's about the mode of delivery, and that's very important. So if we are going to interim study it, I think it should absolutely be a real interim study. I agree this language is problematic, and probably, Representative Weber, the reason that the language is maybe borderline offensive is because of the experiences out of which it was born. And so I think we have to take that into account and be very sympathetic to that. So I would definitely, if we are going to interim study it, think that that's something we have to give some serious and honest consideration to. And those are my thoughts.
Representative Shapiro.
Yes, thank you, Mr. Chairman. I was affected by some of the testimony, especially people who came and talked about not thinking about this very much. There being an assumption that this is what happens to all boys, and then those people maybe had some ongoing medical complications, and I was very sympathetic to those stories. And I feel absolutely that circumcision is an elective surgery, that people should be educated, people should have all the information they need to make an informed decision. That being said, if people continue to work on this bill, I think there's not only, for me, there's not only a change from informed consent to education that has to take place, but I think that people who came, some of the people who came to testify were saying there's an assumption, a bad assumption, that little boys should be circumcised. And this is truly elective. People shouldn't assume that. Doctors shouldn't assume that they can just stick something in front of the mom and get her to sign it. And but what I think this bill, the original bill, does, and what this amendment does equally, is it creates the opposite bias. The bias in this bill is that this is a very dangerous procedure, and you better watch out. You better look at these tools that are going to be used to do it. I would say that just the term potential benefits and inherent risks is a biased way of talking about this. There are potential benefits and potential risks as well. I understand that some of the testimony was compelling to some people, but this was just a slice of people who came to testify about this bill. I mean, there was no testimony from anybody who was circumcised when they were a young child, like I was, and have had a perfectly normal life and a very satisfactory life in regards to health and various things. So I think that this bill was brought with people with a particular bias, and we heard testimony that had a particular bias. And by all means, if we're going to work on something and pass something, we don't want it to have the opposite bias. We want it to be informed, scientific, neutral. We want to create a culture where people can really learn and think for themselves and make their own informed decision. But this I find to be dangerous, to tell you the truth.
Representative Weber and then Representative Nagel.
I just wanted to issue a small apology for my remarks earlier. And I wanted to make it clear that I too found a great deal of the testimony that we heard very, very compelling. And I do not in any way want to minimize that. I just don't think that this is the appropriate solution. But I have to say, the testimony was very compelling. I will also say that my professional development came through divorce work, and one is equally informed by the fact that there are some horrible divorces out there, and those are the ones you hear about. You don't hear about the vast majority of parents who suck it up, talk to each other, make compromises for the benefit of their children, and go on to be wonderful, wonderful, wonderful co-parents in a new setting. So I just wanted to make that apology and make sure that I wasn't minimizing the testimony that we heard.
Thank you. Representative Nagel.
Thank you, Mr. Chairman. I'd like to second what you said because it kind of began what I wanted to say, but I feel compelled to say stuff I wrote here earlier that I wasn't going to say till later, but you nailed it. I mean, this is a very biased presentation. When I started
You're not going to
looking
read 3 pages, are you?
yeah, no. Never mind.
We
I'm
do
not.
have
I'm not reading 3 pages. What I'm going to tell you is the following. I mean, I spent an awful lot of time on this issue. I have no idea why, but to clarify what you just said, the satisfaction rate of males who've had circumcision is 99%. The complication rate, which was really misrepresented, is in a study in Israel was 0.34% In the United States, it's between 1% to 2%, and most of the complications are very short-term and self-limited. And as Dr. Conway, who presented here, acknowledged, the one gentleman had a very serious complication, and in the study in Israel, they had one, but those are extremely rare. And I think we got to be really careful about biasing reality. The other thing you might want to do if you got nothing better to do is I found a website totally by accident of people that are angry at their parents for not having had them circumcised because all the problems they've had from being uncircumcised. So there are definitely two sides of this story, but we're finding out that 99% of us are in the middle and we're just fine.
Representative Land, did you have a comment? Representative Cushman?
Thank you, Mr. Chairman. I think that this discussion is very important, and obviously, there's a lot more to hash out here. I'm going to withdraw my motion, and I'm going to move interim study.
Is the second withdrawn?
Sorry, I made the motion and
Oh,
I
I'm
already
sorry.
offered to withdraw it, so I will withdraw it. And
Likewise.
yes.
I will withdraw my second. And if I may, I just want to say that this is clearly a complex issue. There was a lot of compelling testimony. This is the only routinely done elective surgery on infants. And that's why the gravity is what it is. There's nothing else like this. So that's why it's special and needs to be really considered as far as that goes. I would like to see this studied over the summer and I would be happy to participate. And I think this broader informed consent conversation definitely needs to continue as well. Thank you.
All right, so Representative Cushman, you're moving interim study. Is there a second?
Second.
Representative Weber seconds. Any discussion on the motion for interim study? Representative Murphy?
Thank you. I question about interim study on this bill specifically because it perpetuates the concept of focus on circumcision alone. I would argue that, Representative Shapiro mentioned, and people have mentioned elective. It is an elective procedure in that it does not have to be done emergently. But it's not elective in the sense that you need your total joint replaced, and we can talk about it 3 months ahead of time and then decide to do it. Once you get beyond about a week or 10 days after the child is born, the increased risks are there with circumcision. So it's not, I wouldn't call it elective, I wouldn't call it emergent, I would call it, in a sense, somewhat semi-urgent. A decision needs to be made. So a point of clarification there only. If I were to change the word here, so I'm looking at this, the concept of interim study, and if I were to change the word circumcision procedure to any other procedure we do, we would be doing the same thing. I think there's two issues going on here. One is the concept of the circumcision, whether it's appropriate, whether people like it or not. I take offense, not offense, I question the word cosmetic in a procedure that does have, in Cleveland Clinic studies and other studies, that does have some very definite therapeutic benefits. So it's not only cosmetic. But I would also argue that there are two parallel tracks here. One is the concern we have about informed consent. I agree with that. Maybe we ought to work on that. I'm not sure I would ever get to the point of legislating or putting in statute informed consent language necessarily, but that's a separate issue from the procedure itself. And so my opinion or my thought would be that this becomes, in my mind, an ITL for both the amendment and the bill itself. And if somebody wants to bring up a separate in a future bill regarding informed consent, that could be done later date. So I'm still not sure that interim study in my mind is the best way to go if the presumption is that we're still working on the concept that circumcision is a procedure that has to be focused on in this bill. Thanks.
Representative Weber?
The other option that might be available to us, that is available to us if people are interested in it, would be for the chair to create an ad hoc subcommittee of this committee to study the broader issues of consent, which it's within your power to do. And I don't know whether that would get us farther forward on this bill or not. And the two are not mutually exclusive. We could either ITL or interim study this bill and still have a committee to study a broader issue if that's the will of the chair and the committee.
Representative Tejas?
She can go first, yeah.
Representative Tejas?
Thank you.
So I'm sitting here with a few lenses on. One is I'm a family doc. I did over 200 deliveries in residency, and I practiced in a place where it was not sort of the culture of the families that we served uh, to have circumcisions. So while a few happened, it was a parental preference thing, and nobody was solicited. You might get asked, right, but you weren't lobbied. So some of the connotation that is hard for me to relate to because I don't currently practice right now here. And so that's just a wondering I have as to like how did this come to be? Because we're talking about an elective parental choice, and then the issue of informed consent. Representative Murphy, I really appreciated your elaboration on how it's a conversation, and in current times it is patient centric, right? And I just want to remind us that there is a lot of science and research to how to make informed consent, which may seem here really easy in black and white, how to make that better. So there's a lot that goes into it. It's not just what gets shared, it's sort of the context, the people's state, what they remember might vary. And so it's not been easy over many years to try to improve informed consent. And I'm not saying it's good or bad. I'm just saying like it's not something you can just legislate or create a form and that takes care of it all. So what I've heard is that there's a concern that there's not education happening. I checked in with some OB providers and they'll say they mention it. You know, it gets mentioned during the course of prenatal care that if you're having a boy, this will be something you want to think about. So if the concern is that all parents who are aware of the gender of their expected baby have never stopped to think about what they would want to do when the time comes, then maybe we focus on an education campaign or something else that could easily be done out of a public health department that is not about legislating the practice of medicine. So I think that's it.
Other discussion? Representative Leon.
Thank you, Mr. Chairman, and I want to thank the members of this committee for talking about how important informed consent is. I think our larger discussion of informed consent should actually not address this bill, but should address House Bill 1280, which has been presented in front of this committee on February 7th, which has to deal with informed consent. I think that this is an area that I think does warrant further study, whether or not we're making sure that there's education. There are some cultures where it's assumed that you do, some cultures you assume that you don't, and there's some people where it's a religious right. So I believe that interim study would be a good path forward. If that doesn't pass, I'd suggest that we hold off and move this one to March 6th, so that anybody who wants to bring a different amendment could by a March 6th executive session if interim study doesn't pass. But I think we're probably ripe for a vote, given that we've discussed this pretty thoroughly.
Any final discussion on this? Seeing none? Okay, the motion is interim study on HB 1706-FN.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofalt,
No.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel,
No.
Representative Notter,
Yes.
Representative Weber,
Yes.
Representative McKay,
No.
Representative Freitas,
No.
Representative Cannon,
No.
Representative Nutter Upham,
No.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
No.
Representative Priest,
No.
Representative Tejas,
No.
and Representative McDonald.
Yes.
11-9.
Motion passes 11-9.
Yes.
Okay. Representative Cushman, you'll do the report on that?
Yes, I will.
Okay, thank you.
Is somebody going to write a minority report?
11 to 9, passed it, passed 11 to 9. Okay, all right, so you're doing against interim study?
I think the issue may be that the people who voted in the minority may have done so for a number of different reasons, which are mutually exclusive, but perhaps somebody writing the minority report might want to reference the fact that there were various reasons for voting that way. No, thank you.
All right, Representative Nagel, you'll write the minority report on that? Representative Nagel? You'll write the minority report. Representative Shapiro?
Does the minority report have to reference what they are supporting?
I'm sorry?
Yeah, the minority report would have to give the alternative,
Like ought to pass or
Right.
IPL or,
and that may be a problem because I think some of the people might have been wanting ought to pass and some might have been wanting ITL.
can we have more than one minority report?
I don't think,
I've never heard of that.
I've never seen it, so I have no idea how to
There's-
square that circle.
There is only one minority report required. We had another bill where there was a desire for two.
Yeah.
My suggestion is that we include that there were a variety of different options presented for this bill, which included an ad hoc committee, broader legislative committee, or just the ITL, the bill in total, or whatever. But I think we need to include all those things.
Sure.
I agree. The problem is that we will also, the clerk will insist on whether the recommendation is ITL or ought to pass. And I'm not sure, or ought to pass with amendment, all of which are
We
possibilities.
don't know. We don't know.
Representative Kofal?
Thank you, and thank you, Representative Weber, for pointing out the fact that, yes, some of us did vote against this, not because we wanted to ITL, but because we wanted to OTP. Having said that, I think that I am in the minority of the minority in that view. Therefore, I am comfortable if the minority report presents an alternative motion of ITL, because I do believe, perhaps incorrectly, I would encourage others to speak up if they share my view. Let's put it that way. Otherwise, I think it's safe for us to assume that the majority of the minority would prefer an ITL motion, so that if if interim study fails, that would be the default motion that's made on the floor.
So now I lost you.
You're writing an ITL report, minority report.
So the minority report is recommending ITL, and
For the interim
I would
study.
certainly, the minority report is recommending ITL.
The majority report is recommending
And-
interim study.
Right, and
I see
my,
what you mean.
my request is that minority report should mention that not everybody who voted in the minority agrees with the ITL recommendation.
Well, I'm writing ITL the bill, period, not ITL interim study.
Yeah, and what you're going to do is exactly what Representative Kofalt said. People who voted against interim study voted against it for a number of reasons. Some wanting to ITL the bill entirely, some perhaps wanting a passage with an amendment. And then you say, we had to pick a recommendation, so it seemed like more of the people were on the ITL side this is not the right kind of language, but these are the points you're going to get in there, is that people were in disagreement about what the actual recommendation should be, so the report should honor that. But we are required to pick one or the other, and I think that Representative Kofalt, and I thank you for it, was pretty explicit in saying, more of the minority was for ITL than ought to pass, and we had to pick one.
Can I say that if I don't know that? Because I don't know that. We didn't actually have a vote. I think that's good, taking a bridge too
Well-
far to say that.
The fact is that however you explain it,
Yeah.
there will have to be a recommendation.
Okay.
It will have to be either ought to pass with amendment, which will have to have an amendment number, and we haven't voted on any amendments, or ITL. So you don't have to be terribly specific about it, nor do you don't have to make assumptions. I think the only thing that everybody's agreed on is that it's important to say that the people who were not in favor of interim study were also not necessarily united in what they thought ought to happen with the bill.
Representative Kofalt?
Thank you, Mr. Chairman. And I think if there were a large body of people in the minority who agree with my position, I think we would have heard from them by now. So I think it's very safe to say that most of the minority agree with the ITL position.
Okay.
Anyone else on 1706? We clear where we're going? Okay. All right, now let's revisit HB 1593 FN at this point. Again, it's an early bill. We do need to get it resolved. We have received the latest amendment from Representative Leon. I'll recognize her for a motion.
Thank you, Mr. Chairman. I move that we adopt Amendment 2024-0709H to House Bill 1593.
Is there a second? Representative McLean seconds. Representative Leon, do you want to speak to your motion?
Thank you, Mr. Chairman. This was delivered through from OLS doing a heroic job getting it to us so quickly. It includes that set language that we had. If you flip to the back page, the Department of Health and Human Services shall include language in the contracts designated in subparagraph 4 to prioritize services previously included in individualized budgets, and it has an effective date upon passage. So that's why I had the date changed to this current fiscal year so that we can get these services back. So I think this is what we had. I don't know if we need discussion or if we're ready for a vote when the clerk is ready.
Any comments or discussion on this amendment? Seeing none. Mr. Clerk, whenever you're ready. Motion is ought to pass on Amendment 2024-0709H to HB 1593 FN.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel,
Yes.
Representative Notter.
Yes.
Is that a yes? Okay. Representative Weber,
Yes.
Representative McKay. Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham. Yes. Representative Shapiro,
Hallelujah.
Is that the same thing as
That's a
yes?
yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Priest,
Yes.
Representative Tejas,
Yes.
Representative McDonald,
Yes.
20-0.
Okay, do I have another motion on the main bill?
Yes, Mr. Chairman, I move ought to pass as amended by Amendment 709H on House Bill 1593.
Is there a second? Representative Mazur seconds. Any discussion on the main motion? Seeing none, when the clerk is ready. Motion is ought to pass as amended on HB 1593 FN.
And just to be clear, that was Leon, Representative Leon and.
Representative Mazur seconded.
And s-
Yeah.
and-
Leon and Mazur, yes.
Okay, gotcha. Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
No.
Representative McLean,
Yes.
Representative Seth King,
No.
Representative Mazur,
Yes.
Representative Notter,
Yes.
Nagel?
Oh, you know what? I totally spaced. Okay.
You know, I
I
lost
spaced
so
too.
much
Is it
weight
okay
that
to
when I
change my
turn
vote?
sideways, I'm invisible.
Point of order.
Representative Nagel.
Yes.
Point of order. I made an error in and when I verbalized my vote. Is it okay? Is it possible to change it
Before the end of,
finish?
before the vote is called, yes, you can change it. So you're changing your vote
To no.
to no? Okay.
Representative Nagel.
Yes.
Representative Nodder.
Yes.
Representative Weber.
Yes.
Representative McKay.
Yeah.
Representative Freitas.
Yes.
Representative Cannon.
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro.
Yes.
Representative Merchant.
Yes.
Representative Murphy.
Yes.
Representative Priest.
Yes.
Representative Tejas.
Yes.
Representative McDonald.
Yes.
17-3.
Is that something that can, is there
Got
going to be a
an
minority
got an
report? or-
appropriate, oh,
Go ahead, Representative Weber.
It has to go on the regular calendar anyway because of the appropriation.
Okay, that answers that.
The minority report is another discussion.
Is there going to be a minority report on that, or for the three that voted against it? No, okay. Okay, it's been requested that we move to 1604 next. So do I have a motion on,
So move your amendment.
I'd like to make a motion on an amendment on HB 1604, number 2024-0323H.
do we have that amendment?
He's about to hand it out.
Oh, okay.
Yeah, I have it here.
Okay,
Ought to
motion's been
pass.
made. Is there a second to the amendment?
Second.
Okay. And please distribute it, and then
You want to read that? That's my blurb, and you can give Christina a thumbs up. That's good. Where did the amendments get stuck?
oh, they're coming.
There.
Lisa has.
Second on the amendment.
Yes, merchant.
Thank you. All right,
And you gave her a thumbs up.
I did. Yeah. This amendment will be easier reading than the last one. Okay, Representative Nagel, would you like to speak to your motion?
Yes, I mean, I just want to follow up on the testimony that I originally provided on this bill. There's three parts to the bill. The first part defines electronic medical records. The second part is what I call the provider protection portion, which is number 2. The part that we're striking with the amendment is part 3, which is the patient protection provision. When we talk about the bill, I'll discuss this all in greater detail as to why these are important, but after talking with stakeholders, it became quite apparent that number 1 is that what I wanted to accomplish in 3 is to some extent already in federal and local state statute. My belief and that of my patients and my observations is that it doesn't work. What I wanted to do was create something that worked. It became apparent that this won't accomplish that, and what we wanted to do was strike it from the bill and have a discussion, probably long-winded over the summer, to come up with something that's more workable.
Any other discussion on the amendment? Seeing no other discussion? So the motion is ought to pass then on 2024-0323H, amendment to House Bill 1604 FN.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel,
Yes.
Representative Notter,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yeah.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham, Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Priest,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
20-0.
Okay, do I have a motion on 1604 FN?
I'd like to make
Representative Nagel.
like to make a motion out of pass on HB 1604 as amended by the amendment.
Okay, is there a second? Representative Leon seconds. Do you want to speak to your motion?
Sure. I mean, I gave a pretty long-winded discussion about this bill before. I don't know that I want to add much more to that, but the first part is a definition, and I really feel strongly that if you're going to put terms in statute, you need to define what you're talking about. So that's why the first part has a definition, which did not really appear in statute prior to this. The second part is intended to be to provide protection to doctors, and I'm just going to give you a brief story, but I met with a Democrat governor of which state I won't mention a couple years ago, and he asked me a question about the Affordable Care Act, and he asked me what did I think about it, and since we weren't meeting to talk about that, I wasn't really prepared, and I certainly hadn't read the 2,000-page version of it. And he looked at me and he said, it's all about cost and access. And he said, this may improve access, but it's going to accelerate cost. And that's going to be a problem for private practices. It's going to be a problem for patients and so on and so forth. So inspired by that, I actually read the entire thing. A couple months later, I happened to talk to the head of CMS for the Northeast region, and I asked him, I said, after reading this, I have some serious concerns about the Affordable Care Act in terms about patient access, especially for complex patients and miscellaneous other people. And his response to me was that the train's left the station, you're either on it or you're not. And my response to him was, my concern is your rear wheel's off the track. And I'll be more than happy to catch up, and when the train falls off the tracks totally, I'll try to help you get back on. There were two issues that were important in that discussion. One was prior authorization, and the other one was the electronic medical record. I provided a quote for you with the original testimony about my concerns about how people that are in IT feel about the disaster that the electronic record has been and how it's harmed communication between doctors and patients, cost of private practice, which I think should be the bedrock of healthcare. And so I won't go into that any further, but my attempt here is to try to put the train back on the tracks in a direction I think we don't really want it to go. The other thing that inspired me in doing this is I believe in whole person integrated care. And right now we have a whole bunch of providers that are excluded from that model, such as chiropractors, acupuncturists, massage therapists, and other people who have a lot to contribute who are not being included now, and it's my sincere hope that they will be in the near future. This bill would allow them to do what they're doing without being forced to use an electronic record to submit their bills and things like that, because to be honest, that would threaten their financial existence, and I don't think that's good for patients or providers. And I think on that note, I'll end.
Representative Weber.
Thank you, Mr. Chair. And first of all, I'm incredibly sympathetic to the points that you're making because I think they're right. Okay, so that's item number one. Item number two is I have a concern with paragraph 2 of the bill because I talked to a colleague on commerce, and they're concerned that it is in direct conflict with federal law. And I don't know enough about this area to be able to deal with whether that's okay or whether that's not okay. And I was wondering if it would be possible for us to put this off and have our researcher do a little more research on that issue. Because on the one hand, I would like to do anything in my power to make this particular situation better. But I don't think getting us into a conflict of laws state, if that's what's going to happen, would actually get us farther forward. And we may be removing one more wheel from the track, which I would rather not do.
Representative Nagel, do you have a response?
Sure. So one of the points that I made when I presented this bill originally was that I had a very, I'm sorry, this is a little bit circular, but I work with the University of Rochester School of Healthcare Policy Economics, and they voiced a concern that it's not that is happening. It's really happening, is that we're witnessing healthcare being taken over by increasing size of entities. That they use the electronic record for data collection and for billing purposes to the harm of patients, basically. I mean, we've lost our focus on what we're doing. This is true at the federal and state levels. My original reason to bring this bill actually forward was to make a very, very, very public statement that we got to stop this. And it's not just a local level, it's a federal level. And what's fascinating to me was the prior authorization bill that I initially was brought for the same reason. In the process of us doing that, we put a lot of pressure on the federal government to realize what they're doing is wrong with that as well. And in the end, they ended up passing legislation, or recently CMS just passed a total change in the way they're doing prior authorization that totally mirrored the bill that we created. And so now we have two parallel bills that both will solve a problem. And it's my intent that this is a very public statement that what you're doing is wrong, that you can't require people to be your data collectors and your billing people, that you can't ruin people's practices, and that you need to stop doing this. And that I think that my hope is that what we're doing here will not conflict but align with what should become federal policy.
What about the suggestion, now you made the motion to, about to pass as amended. Representative Weber has suggested further research. That was my specific question.
I mean, my gut sense is I really want to go ahead. And this is going to be really rude and Lady Godiva-ish of me, but I think that making this statement's incredibly important. And I understand your point because it's been raised twice to me now by two different insurers who both agreed that this bill's a good idea, but both said what you said. So
Representative Shapiro and then Representative Merchant.
Yes, I know there was some questioning of whether this should have gone to our committee or Commerce in the first place. And I'm wondering if we pass this bill and can we make a recommendation that it go to Commerce, or is that?
It's going to be, well, I would make, it's going to be too late for an early bill at that point.
The clerk's standing there and shaking his head.
There's your answer.
But I would love it.
Representative Merchant.
Thank you, Mr. Chairman. I do have concerns about the federal ERISA, the Employee Retirement Insurance Safety Act, which was passed in 1974. And that will take precedent over any state law. So what I'm not sure about is, back to Representative Weber, are we running into a situation where the federal law trumps the state law in this arena? And I really don't know. I think we need to find out. I also would say that if you wanted to change it, Representative Nagel has put down that any public health carrier governed by state law versus federal law may be at least a way to avoid the conflict between the federal and the state.
I'm really sorry. That was a great point. And one of the things that you and I have learned in our 6 years together on all the stuff we've done is that what we do here has a very small effect on the healthcare system as a whole. What I write here can only affect state, not federal insurers. So what we would write here would have no effect on Medicare, Medicaid, whatever. So I think that's a wonderful idea.
So would you be open to amending the amendment to be sure we're only talking about state law and not run afoul of federal law.
That's fair. I'm fine with that.
So are you then saying you're going to withdraw your motion?
We quickly go up to the fourth floor with the draft and get it to OLS to get it to the fourth floor to pass out to our colleagues to review the amendment.
All right, so you had seconded, right?
I'll withdraw my second, and just as a little bit more of that procedural, we have hearings in the afternoon, and we actually have noticed to continue our executive sessions tomorrow at 10:40 after 2 hearings. And I know OLS is pretty stressed, so I think we'll be able to have it in time for that. They have quite a few amendments given the deadline. So I think if we aim to try and have that for tomorrow when we restart executive sessions at 10:40, I think that'll be a great way to get this done.
And I would just,
Representative Weber.
I would just add that I very much appreciate that amendment, and that would make me much happier. It's probably true anyway, but I would be much happier in voting for it. So thank you all very much.
Okay, so, and I know there's some scheduling issues, some individual scheduling issues from what I understand.
And we've already noticed that tomorrow we will continue executive session. We actually may be able to see what happens after our hearings today. I don't know if there's a problem with anybody being able to attend that noticed executive session at 10:40, which is well ahead of the caucuses and session.
Mr. Chairman,
Representative Merchant.
it's more of a timeline. Can we exact on something tomorrow and still get a community report in time to get it into the calendar?
No. We've done all the early ones,
This
yes.
is, but this is a fiscal note. Wouldn't it have an early one?
It's not early.
Yeah, all fiscal note bills
Yeah.
are not necessarily early.
Oh, okay,
ones.
thank you.
No, the 2 early bills that we had to get done, we did get done, and I should have mentioned this at the beginning. There was a little confusion about HB 1585. That has been continued to March 6th. It had been previously announced that it would be,
Yeah. Well-
we would continue it to March 6th, and then we mistakenly had noticed it for today, so. Representative Weber?
I think there's some question here about timing, and I'd love to hear about it, but we do have a session noticed tomorrow. And I think we have, what, 3 bills left? Is that correct?
4. Well, if we put 1604 off, we'll have 4 tomorrow.
Oh, okay. Well, in any case, we could, but all of the bills that we have left to take up are not on deadline. So none of them are on deadline, so they don't have to be finished. And
If I could, then, if it's not on a deadline, could we hold off until next week when we exact on those bills?
it's up to the
Chair.
chair and to
Is there a
everybody
specific
else.
reason you want to put that off, or?
To take off some of the pressure on OLS and the people upstairs. in the fourth
It's
floor.
only a couple of words for this one, so
Okay, all right.
I think tomorrow's okay
Okay, all right.
rather than next week.
It's always good to move it along as quickly as we
all right.
can.
Getting them off our plate is a really good thing if we can get it done. If they can't get it done, then they can't get it done and we can't vote on it, so.
So based on this conversation, we would be continuing HB 1683 FN, HB 1660 FN, HB 1568 FN, and HB 1604 FN. Any questions? Okay, and again, we have hearings this afternoon, and we will recess until then.
Nice. And then that gives us 11 more minutes of lunchtime before hearings.
So we're, Mr. Chairman?
Yes.
So we're putting off these other bills as well? Okay, okay. Does that feel okay to you? Sid, to
No,
put
I'm
in that
fine
language?
with it. I'll be honest, I mean, I knew it was a problem beforehand, and my intent was never to infect federal. I mean, I'm happy people called me.
Yeah, I mean,
No, that was a brilliant call.
I think in the reality is, if it passed, it just wouldn't
I think that that's right. If it passed, it
just
simply
wouldn't
wouldn't
apply.
have the effect, but I think it's much better
Just make it.
to make it very specific, that we understand what we're doing as opposed to, oh, we didn't know what we were doing.
We should, I mean, I should have been more proactive about that, but you know, with that said, I mean, it's kind of inspired me to have meetings with Team Shaheen and whatever, you know, about, you know, this issue, because it's, you know, I was shocked that CMS literally passed that statement 2 days before our hearing on the other bill. And that, it dramatically on the prior authorization bill, and I was like, all right, fine, you guys are looking at this stuff, this is great. So, you know, I think we can pair our efforts better. It gives me a reason to meet with them.
Yeah, and you know, I know from being a small provider that this affects a lot of people.
Oh my God, well, if you're like a chiropractor.
I mean, the last 10 years I was in private practice and I couldn't afford a medical, not only couldn't I afford it, it would have driven me to suicide.
Well, if you're, well, to be honest, it's doing that to a lot of people now, and it's the reason why, you know, they look
It
at
would
the
have made me
electronic
quit.
record as the leading cause of burnout.
Yeah, but yeah,
And that's, I mean, we're talking like 60% of the variance.
So my thought is here, it says no public or private healthcare. Okay, so on line 8, all we're doing is saying no public or private healthcare carrier governed by state law shall.
right. You're a master reconciliator.
Okay, where are you, David?
I have a question. I mean, I still need to
Good afternoon, everyone, and welcome back to the Health and Human Services and Elderly Affairs Committee of the New Hampshire House of Representatives. First bill for a hearing this afternoon is HB 1028, and I'll recognize the prime sponsor already in place. He must have done this before, Representative J.D. Bernardi. Welcome, Representative Bernardi.
Thank you, Chairman McDonald and committee. J.D. Bernardi, Rockingham 36, Hampton Falls, Kensington, Southampton, Newton, and Plastow, Southeast New Hampshire. The sponsor of HB 1028, a bill relative to the definition of mental illness for the purposes of the New Hampshire Mental Health Services System. I provided a copy of the bill in larger print for everyone. Hopefully it's in front of you. And I invite you to look at the definition, RSA 135C 2 Roman X or 10. And the interesting thing there is focus on the last sentence. And I think you can understand that treatment of impairment for emotional processes can be and should be different if the issue is epilepsy, drug addiction, or alcohol addiction, or other intoxication. Yet intellectual disability has been lumped in with that category. That's an inappropriate segregation, and as noted in C:3. It is also, there's segregation there for co-concurrence with development disability. So I know you received comments from the New Hampshire Community Behavioral Health Association that said services are available to these folks, services are provided for these folks, nothing it prohibits their treatment. But I filed this bill on the behalf of folks who are not being adequately treated. And that's what needs to be addressed. I'm not going to go into a big discussion of those issues. That you have several pink cards of people who want to talk about the exact rationale for that, and among them is Ann Sanick, who was the driver of this bill's presentation. So I'd be happy to answer any questions, but I would really like you to hear their stories.
Okay, any questions for Representative Bernardi? Seeing none, thank you.
Can I go?
Sure.
Sonic. who
Your
you
name
mentioned.
again was Ann?
Ann Sonic, SANOK.
Okay, you can proceed. We do ask all testimony be kept to 3 minutes, please.
To what, how many minutes?
3.
3, oops, okay.
Um,
I'll try,
it was
I'll
close-
talk fast. All right, well, thank you, Representative Bernardi, and thank you, Chairman and committee members. As represented, my name is Ann Sonic. I'm a parent of a 28-year-old young male who is intellectually disabled and autistic. I've been involved in the field of developmental disabilities, as you'd understand, for many, many years. I'm presently associated with One Sky and on the board of directors for Farmsteads of New England, a residential day program for people with intellectual disabilities located in Epping and in Hillsborough. I live in Exeter. I'm an attorney and I teach business law at Southern New Hampshire University. As Representative Bernardi pointed out to you, really what we're targeting here are the definition sections under the mental health statute of 135C:2. It defines mental illness, and there's a clause in there, shockingly, includes a clause which excludes those with intellectual disabilities from mental health services. It says it does not include impairment primarily caused by epilepsy, intellectual disability, related drug or alcohol problems. So really what we're looking for is to remove that clause from the statute. really, we're trying to end discrimination against persons with intellectual disabilities and improve the mental health services in New Hampshire. It's been an evolution. Obviously, mental health has changed dramatically over the past decades, indeed centuries. There's always new insights into mental illness, advancements in science, education, medicine, and law. It's certainly a process of trial and error. And one of the main errors that still remains a huge problem, it's been a detriment and major impact on individuals in intellectual disabilities, their families, and certainly the pockets of the taxpayer, is that persons with intellectual disability are often the ones stuck in ER for weeks, months at a time. You've all heard about the problem with ER boarding going on in the hospitals in New Hampshire. I can attest to that. Having my son having been in there for 28 days in Exeter at one time. The ER is not equipped, as you've heard probably in different meetings, to deal with problems of psychiatric boarding. The state hospitals refuse to admit them, often, not always, despite having all the resources to handle and treat said persons with intellectual disabilities. And so they sit in there and their warehouse there often for, my son was for 28 days. While he was there, not one doctor, not one social worker from the community health center or state employee really had a solution. He was clearly in the throes of a psychotic break. And that's why we brought him there. That's why these parents bring them there. They're not like, hey, let's go to the emergency room today. There's a major problem going on, and it's very different often than what has been going on at home with the person. That's why every person with intellectual disability ends up in the ER. They're told to go there by the community mental health centers and by the area agencies, by their social workers, by the doctors. Everyone goes, go to the ER. And then they find that nothing really happens. New Hampshire State Hospital refused to admit my son at that time on grounds he was autistic and that his symptoms and behaviors were only related to that or primarily related to that. And that brings me back to that clause in the statute which says primarily impaired due to. They latch on to that, becomes the pass, free pass, that they don't have to address it.
Yeah, if you could start, please, wrapping up.
Okay. Basically, this can't be resolved by it's not my department mantra, and that's what that provision in the statute does. Everyone cannot stay in their own lane on this issue, and with the language that's in there. There needs to be a conduit between the state agencies and removal of this phrase, which expressly excludes individuals with intellectual disabilities from our mental health care. And this would be a step in the right direction. The subject clause only exacerbates the problem. Removing it will motivate the mental health system in this state, as well as the other ancillary organizations, to work together to address this gap in the system and end the discriminatory allocation of mental health services. So I urge you to support this bill on behalf of people with intellectual disabilities who have really been shut out of really important care and treatment. Thank you.
Thank you. Are you taking questions, or?
Oh.
Representative McLean?
Thank you, Mr. Chair. Thank you for taking my question. Do you understand the history of why this exclusion is there in the first place?
I think I do. I think it's sort of twofold. One is to make sure that people with intellectual disabilities don't get mislabeled as mentally ill. But I think the other primary reason is really it's not my department. That there's a really sort of you're intellectually disabled, these people are mentally ill, these people are this, and it's not that clear. There's not that defined distinction in reality. And to exclude them, it does have doctors. A lot of doctors and psychiatrists are not really familiar with people with intellectual disabilities, with Down syndromes, with autism. They don't get it. That's not what they do. Just like the heart surgeon doesn't know about setting a bone. And it becomes because there's that presumption. It's like a legal presumption that's been put in, an unjustified legal presumption has been put in the statute. That's a trigger and a signal to these psych units and hospitals to go, no, we don't have to do that because it's primarily caused by your autism or your Down syndrome, your behavior, whatever you're doing. If you're aggressive, if you're, having illusions, and that's wrong. It doesn't work. I think it might have been well intended for sure, but it's become that's the reason why people are sitting in the emergency rooms. And then ultimately, I would tie it to the fact that many of these people with intellectual disabilities, after they've been in the emergency room, no place to go in New Hampshire. You know where they're sent? Texas, Massachusetts, Pennsylvania. We're spending up to $500,000 sometimes on these people. If you just took the time to stabilize them, you might have avoided that major life event and crisis.
Follow up?
So just a quick follow-up then on that. In the case of your son, who was kept at the ER for 28 days, what was the ultimate resolution there?
He never got admitted to, they were trying to get him to New Hampshire Hospital. They actually took him up in an ambulance while he was there, like a week, took him up. He was in there less than 10 minutes. He didn't even get off the stretcher. They sent him back and just phoned and said, not taking him. He's autistic. So he stayed in the emergency room again, 28 days. And then finally, the Bureau of Developmental Services, after, scrambling around, found a placement in Massachusetts, the Judge Rotenberg Center. And he was taken down there by ambulance. And he was really stable, within a week of being there. He ended up staying there for a longer period. But yeah, I mean, we need to deal with this stuff in house, and we need more cooks in the kitchen on this, not less. And these people need to work, and it's not going to disrupt the system by taking out a phrase. It's going to force the parties to talk together, new policies, new arrangements, new conversations, instead of going, not my department, next window.
Other questions? Representative Nagel and then Representative Merchant.
Thank you, Mr. Chairman. Thanks for taking my question. First of all, I would like to thank you and the sponsor for bringing this bill in. This is very important to me personally, and I really appreciate that you did it. And I think it's simultaneously sad that you did it. Comorbidities are really common, and we really can't differentiate. What I'm wondering about is, number one, how pervasive do you think this problem actually is, and is there any relation to severity? And the only reason I ask that question is I have an autistic son. He's, quote, high functioning, whatever that means. We've never had troubles with the mental health system, and I'm just curious if this issue is as pervasive as you're saying,
It's pervasive for a small population. And if they go to the emergency, I would say it's extremely pervasive. So yeah, it's not going to impact a huge amount of people, but I can't even tell you the hell that we go through when you're in that situation. And New Hampshire's under a court order by the district court to end ER boarding in 2025. Actually, it's supposed to be 2024, but I guess there's an extension till next year. Are these folks factored into that equation? Is the mental health going, oh yeah, okay, we're going to board more people now in our own psych units, take them out of the ER, but not you and not you and not you. So what's the hospital going to do? I mean, the mental health system needs to take some ownership of this. It has to be a shared allocation of resources and shared delivery of services. And it is pervasive for the folks who do have intellectual disability and do go to the ER, and they're not being taken. Occasionally they are. And sometimes they do receive services at the community health centers, but not always. My son is denied services at Northern Community Human Services up in the Conway area because he can't participate in talk therapy. He does need he needs half these people, if not more, are on antipsychotic drugs and antidepressants. They're taking the same medication that normal mentally ill people are taking, or there's people among us who are on that. You function, live your life. they won't see him because he can't participate in talk therapy. Well, now they have to go find some contractor doctor, which works fine for him. But again, another example of, well, we don't do it that way. Well, you need to accommodate this particular population and do it differently. That's the point.
Representative Merchant, and then Representative Shapiro.
Thank you, Mr. Chairperson. Thank you for taking my question. I concur this is a very important issue that we need to solve and do it correctly. And terminology is so important both in statute as well as rules. I'm looking over, you brought up the issue of autism, and based upon what I've been able to find on Google, Dr. Google, Mr. Google, autism is not considered a mental illness or intellectual disability. It does cause issues with learning per se, but it's not listed as a quote mental health issue. So I want to be sure that we don't somehow exclude what I think you're trying to get to is children with autism that need to be taken care of, because if we don't use the right words, we may inadvertently have a unintended consequence.
Autism isn't in there. I mean, it's a good point. I mean, it's a question of semantics a lot of times. Typically, though, I would say they use the word intellectual disability because you can be on the autism spectrum and not have an intellectual disability. So technically, under this framing of the language, you wouldn't be excluded. But believe me, if that word autism slips out of your mouth and they call up New Hampshire State Hospital, they're going to hang their hat on that because it's equated with intellectual disabilities. And many people with most people, when you're associated with an area agency, they're the ones who deliver services to those with a developmental disability. The people often that they take who are autistic or Down syndrome, they do have an intellectual disability. It's just different words are often interchangeable, but not always.
Follow up.
Thank you for that. And I do concur. I think a lot of times words are semantics, but they're important semantics. And I just want to be sure that whatever we're writing in the bill, that we get the right words that we need to take care of the issue we're trying to solve.
Well, I think if you take out the word intellectual disability, they shouldn't be saying, I'm denying you because of autism. They do say that. But really what their meaning is, we see you as, and that person may be intellectually disabled. Often they are. I call my son autistic, but he's definitely intellectually disabled. That's a lot of syllables. So it's just easier to say they're autistic. People kind of get that. If I say he's severely autistic, that's even a better description. But I think if you remove the phrase intellectual disability, there'd be no basis to carte blanche deny somebody. Certainly doctors can make assessments and in their own professional judgment evaluate, but you can't do it over the phone, and you can't do it in a 10-minute thing. You need to talk to the parents, you need to talk to the school, you need to talk to the primary, you need to look at the medical records. That's not happening, and that's proper standard of care. They just go on the word autism or intellectual disability, case closed.
Representative Shapiro, and then Representative Kofal.
Thank you, Mr. Chairman, and thank you for taking this question. I hear your frustration with receiving or not receiving mental health services, whether it's New Hampshire Hospital or services in the emergency room or just outpatient services from a community mental health center. I hear your frustration and I understand it, and I think that our mental health infrastructure is really lacking in this state for people with developmental disabilities and for people without developmental disabilities. So I understand completely why you would want to put in the second part of this bill, an individual shall not be determined ineligible for services under this chapter based on a co-occurrence of mental illness. That makes total sense to me. I'm less clear why you're interested in making the other change, which crosses out parenthesis B, intellectual disability, because just like you said in the beginning, you don't want people to be assumed. It says it does not include impairment primarily caused by these conditions. So like you said in the beginning, you don't want the assumption that someone is mentally ill if they're not mentally ill, but they're developmentally disabled or they have epilepsy. So it's a little bit less clear to me why I'm not sure if you're the one asking for the change, but it's a little bit less clear to me why you want that change.
Because I think that first of all, I don't think that group needs to be in there, number one. Why are they in there? Why is it until, yes, it's really, you're removing that and then you're reiterating the reminder that co-occurring can occur, basically. That phrase, intellectual disability, just needs to be taken out of the bucket because it's a trigger and it's a signal to mental health professionals that, oh, this isn't, they're not going to be able to see what's happening. And it allows them to kind of gravitate towards that as the causation rather than sort of keeping an open mind and really examining everything. I think does that answer your question? Say it again.
No, I think that does answer the question. I'm not, it's not, it doesn't respond to the logic, but it responds to the message you want to give to people.
Right.
They shouldn't exclude these people because they have
I
a
mean, somebody
developmental
from the
disability.
community mental health center will tell you, oh, we treat people with co-occurring. And they do have people with intellectual disabilities go in there. Not always. Sometimes they will say not. But, really, my main focus is sort of the ER boarding and the lack of short-term or long-term psych inpatient care. But I think removing intellectual disability just changes the conversation. Like, you have to deal with this. This is a co-occurring. We're going to start there. We're not going to go, oh, what is primary impairment? Is it 90%? Is it 60%? Is it 40%? Are we going to get into that? It's impossible in many instances to parse that out. Doctors, certainly still have that discretion in their professional judgment to make an analysis and an evaluation of the person. But basically, my point is that phrase is really shutting the door in many instances. I've talked to many parents, really over the last 6 years, I get 5 or 6 calls every year from a parent. I heard you went through this. What do I do? I'm in Elliott. My son's been in there 14 days, blah, blah, blah. And they just called and said autism. That they got a phone call from the state hospital or from a psych unit. They didn't even see the person. They just have the ER report and they call and say, "Oh no, we're not taking them." So that's why I want that out.
Follow up. So it's your experience or experience you've heard about that specifically New Hampshire Hospital excludes people even if they have a co-occurring disorder.
Sometimes they do and sometimes they don't. But they have.
Because they have the.
Yeah, I mean, I realize there's a bed issue
Right.
too, and that could be a justifiable, but I do think there's cherry picking going on, and I think that phrase helps. It's just discriminatory to me on its face.
Thank you.
Representative
Thank you for the question.
Representative Kofalt and then Representative McKay.
Thank you, Mr. Chairman, and thank you for taking my question. So following up on Representative Merchant's question, if we were not to remove anything but to just add something like comma including autism, or if we were to specifically include autism, would you have any reason to object to that?
Yes, I would. I think that would complicate it, not simplify it. I think if we remove it out, that the doctors, you're just going to deal with the person based on the symptomology that's being presented in the entire medical history. Why is that in there? It's an unjust presumption of ineligibility, and it should not be a legal presumption. I think taking that out, like I said, doctors still have discretion, who's doing the admissions and whatnot to evaluate the appropriateness of that admission. But to just go over the phone, they're autistic, we're not taking them, or I don't understand this. And believe me, they do not understand it. There's a diagnostic manual that many people, even at the community health centers, are unaware of. You've heard the diagnostic manual for, psychiatric symptoms, and this one is DM2ID. I have a friend who's a therapist at Seacoast Mental Health. She said, never heard of it. We didn't have it there. Wasn't trained in it, social work school, never had a training here. You know, if anything, by doing this, you're going to make the mental health community more educated and aware of developmental disabilities. And they can use that expertise to work with the Bureau of Developmental Services, with the area of agencies, say, hey, let's come together and come up a solution. Maybe they can have some dedicated beds or people trained in developmental disabilities. They can go there instead of being boarded at the ER. They're going to have to go there in a year. And they can't deny them. And if they do deny them, there's going to be a lawsuit. They need to be trained on this and educated. Like I said, mental health is an evolving process. There's all new information discovery. We want, like I said, we want more people on this, not less. And that's why I think that phrase needs to be removed.
Follow up, Representative Kofalt.
Yeah, so I want to clarify my question. I'm suggesting that in the language that is added, that said an individual shall not be denied, that we would specifically add autism to that so that it is very, very clear that intellectual or developmental disability shall include autism. You're saying you would object to that?
Oh, no.
Okay, thank
no,
you.
You can
That was my
include that.
question.
You know,
Thanks.
just more people might want to add other definitions, but yeah, that would be
Representative
fine. I
McKay-
wouldn't have it. I don't think anyone
Representative
would.
McKay and then Representative Weber.
Thank you, Mr. Chairman. I probably should have asked the sponsor of this bill. I feel that these statements do not reflect the system that's in effect in New Hampshire. New Hampshire has a very comprehensive program in mental health and community mental health services. The DD population is totally separate from that.
It's not separate, sir. It's not separate. They're connected many times. Many people with intellectual disability, autism, and Down syndrome are on antidepressants, anxiety medications. They're on antipsychotics. They're on mood disorder drugs. It's not separate. It's no different than any of the regular population, the currents of mental illness in people with intellectual disabilities and your regular population. It's the same percentage, so it's not separate. And they need to be joined together, and there needs to be communication. But I'm sorry, I interrupted you.
Yes, you did. My background is mental health. I used to be in charge of community mental health services. I was in private practice as a psychotherapist for 35 years. I have 5 college degrees. So that some of the things you're saying are based on the pain that you have experienced dealing with the system, because they're not accurate, what you're saying. And I can see people sitting in the audience who are agreeing with you. I hope there's somebody from the department, for example, the department produces every 10 years state mental health plan. I don't know if you're familiar with that.
I've heard of it.
I wrote the one before this. And not one part of that was ever implemented because we hit the recession. The cost of mental health services is extensive, but what this does is not describing the mental health system that's in effect in New Hampshire. Well, what it does show is some of the complaints that people have had. And I have been very strong about what we call the borders, the number of people who are, like today, if you go up to Concord Hospital, you go down a certain ward, there are people in there that New Hampshire Hospital is not ready yet. They don't have the vacancy to have those people in there. The legislature has passed new legislation. They're building new facilities. And I could hope that the families of those with mental illness would be the supporters of developing a more comprehensive system rather than than attacking them. It's an extremely complex issue, but that I think New Hampshire, over the last 20 years, has done a remarkable job of providing care to the most severely mentally ill.
I agree with you in a lot of respects, but there's a gap, and they haven't been providing significant care to this population. And we do, by passing this bill, I feel like we're contributing in a positive way to improving a comprehensive mental health system. I mean, certainly anyone in a leadership position and who's been involved in mental health for a long time, you know, you see the great work that you've done and you want to tout that. But you're hearing from people in the trenches, from the people who are there day to day, and you're like, you know what, this isn't working for this group. And we've been saying that for a while, and nothing's changed. And sometimes the only way to change things is through a law. And by this law and by removing that phrase, I feel that it can improve it even more and make those new beds that are being developed, dedicate some of those beds to this population. You're the agency that, you know, you worked with for so long. They're the ones equipped to deal with people in psychiatric crisis, not the ER. It doesn't matter whether the person has autism, Down syndrome, an intellectual disability, or anything. The mental health is equipped to deal with it. And whether that person goes in for short term for a issue while the Bureau of Developmental finds you know, maybe they can't return home and they need to go into residential placement. ER is not the place to stabilize them. The mental health organization is. And so that's why we want to improve the overall delivery of services and make it fair to everyone.
Follow up.
Follow.
I know I'm not going to get any place with my point of view. I'm hoping that somebody from the department.
You have to ask a question. You can't state your
Okay.
when the department comes up. You can ask them a question.
Actually, I don't believe any from the department is here, at least not signed up yet. But
Let me just say, would you believe that perhaps the legislature might form a study committee to look into the concern that you have?
I mean, I don't think it's that complicated. I think you can avoid that whole delay and just remove the phrase and then let the parties work it out together. You know, study committees are good, but I think that you know, I think it's a really common sense and clear solution to this. And if I
Thank
thought
you.
otherwise, I'd say so, but I don't.
Thank you very much.
Thank you.
Representative Weber and then Representative Merchant.
I think my question was really a follow-up to the questions of both Representatives Merchant and Kofalt, and was based on the question of autism not being exactly the same thing as an intellectual disability. It's not that there may be overlap, but there were not. And I think your answer to Representative Kofalt may have clarified the issue for all of us. And are you still saying that it's okay to that perhaps use autism as a specific add-in to that last part of the statute?
You know, well, yeah, I wouldn't be opposed to that, but then I'd be worried that, well, with people with Down syndrome, they're like, well, he doesn't, my kid doesn't, I don't think he has autism, he has Down syndrome. Now, what about him? I don't know. You know, I just feel like intellectual disability is comprehensive enough.
I may have a
but-
follow-up.
yeah.
But my problem is that intellectual disability is not necessarily coextensive with autism. You could have somebody with autism who is very high functioning, who then has mental health issues coexisting with their autism. And I'm speaking from knowledge of a family member. I don't want what I'm trying to work
Yeah.
at is the language that will include all the people we want to include
I
and
mean,
not
maybe
exclude some.
maybe in the tag could be shall not exclude people with intellectual disabilities, people with autism, people with Down syndrome, who have co-occurring, diagnosis or symptoms. It's not really even diagnosis because they haven't gotten it yet. I think removing the term intellectual disability, autism, technically, like I said, I think a lot of medical providers equate that term with autism. But you're right, certainly there's people who don't have an intellectual disability, and if they say the word autism, but if that word phrase is removed, I think that removes that technically that presumption for anything. There's technically no presumption that autism isn't in there. It's grouped under intellectual disabilities. So once you remove intellectual disabilities, to me that falls under that umbrella, and then they would have no basis even now of denying them services if there was no evidence of an intellectual disability. I think that they may at some time, but if they,
Representative Merchant?
My question was answered.
Okay. Other questions? Seeing none, thank you.
okay, thank you.
Also signed up to speak is Karen Rosenberg from the Disability Rights Center of New Hampshire. And you've got 3 minutes.
Good afternoon. I'm Karen Rosenberg. I'm the policy director at the Disability Rights Center, the state's protection and advocacy system. I've held the role as policy director for just a little over 2 years, and for the 15 years prior to that, I represented clients in all kinds of matters involving their disability. And I can tell you that it's pretty common in our office to hear from people who experience a developmental disability or intellectual disability to be denied services from the community mental health center. And it's problematic. It feels kind of like a NIMBY situation, not in my backyard, because you've got someone who experiences both an intellectual disability and a mental health impairment, and then they, go to the area agency. The area agency says, well, you gotta go to the mental health agency because you're really, you're in the throes of a mental health crisis. And they go to the mental health agency who says, not so much because you've got a developmental disability or an intellectual disability, and so you're really not ours. And then the person's nobody's. And when I've represented clients who experience co-occurring developmental disabilities and mental health impairments who are fortunate enough to have private health insurance, they are able to get their needs met. They get both, they get all the needs met. They get their developmental needs met, they get through the medical system, they get their mental health needs met through their private practitioners. And it seems really fundamentally unfair that our law on the books would preclude people from being able, who experience developmental disabilities or intellectual disabilities, from getting those services. I understand there are some community mental health centers that are doing a really good job of collaborating and are seeing people who experience both. But the fact is, our current law is something that another mental health agency can rely on to deny services to someone who really needs it. So for all those reasons, the Disability Rights Center strongly supports passage of this bill. And I'm happy to take any questions.
Okay, thank you. Any questions? Representative Weber?
I'm just still trying to explore this concept of, are we being broad enough? Are we being inclusive enough? And as I'm looking up DSM-5, I'm realizing that I may not have had the proper definition of intellectual disability, but the subject of developmental disabilities has also been raised in this context. And I'm wondering what you think about the inclusion of those with developmental disabilities as well as intellectual disabilities.
So are you talking about the second part of the bill?
Right.
Right. So it currently
Or
does.
is that addressed elsewhere in statute, if you know?
No, I think it would need to be in this bill, that you would need to make it clear. And one other thing you might consider is getting rid of the double negative. I think there was some confusion about what the double negative meant. It was making my head hurt. You might want to consider language like, an individual shall not be denied services under this chapter on the basis of co-occurrence of mental illness and an intellectual or developmental disability. Now, I think developmental disability encompasses autism. There are people behind me who know more about this than me. Another population that is not included in this that you might consider are people who have brain injuries, because those are also folks who may have co-occurring mental illness along with having experienced a brain injury, who could also benefit from mental health services. So this may also present an opportunity to ensure that those folks aren't similarly denied services.
Thank you. That's very
Other
helpful.
questions? Representative Cushman.
Thank you, Mr. Chairman, and thank you for being here and taking my question. We're starting to build a bigger list of groups of people who we don't want to exclude. And as I'm listening, I'm a nurse and I've had many patients. I deal with the geriatric population primarily, patients with dementia, who many are on psychiatric medications. And so I just have concerns about these, adding all of these categories that we're going to inadvertently miss somebody. What are your thoughts on that?
That is really interesting. I mean, one thing you could consider is a sort of a catch-all, including but not limited to situation. And probably a clinician would be a better person to craft the language for you. But it might be, you could have something like, a co-occurring, let's see, basis of a co-occurrence of mental illness and an intellectual developmental or other condition, impacting, I don't know, some kind of brain functioning. But like I said, I would defer to a clinician to really get the exact language for you. But that's a really good point, because you're correct. People who experience dementia often are in this situation where, especially in the beginning throes, that they experience a lot of anxiety and benefit from medication and some therapy.
Other questions? Seeing none, thank you.
Thank you all.
Also signed up to speak is Matthew Losdaro from One Sky Community Services. Good afternoon.
Good afternoon.
You did ask for 5 minutes, sir. If you could keep it to 3, I'd appreciate it.
I think I'm going to keep it very quick. There's a lot of other voices in the room that are far more educated personally and experientially than myself. My name is Matthew Cudero. I'm the CEO for One Sky Community Services. I'm here representing my organization only, not our trade association, and not any other area agency in the state. So I just want to be very clear. Over the last 4 years, I've been CEO of One Sky Community Services. We've had, last year, we had 14 people come to the ER that had some co-occurring issues. But we've had 5 individual cases that, including Ms. Sanik's son and another individual that we have in the room today, that could have significantly benefited from intervention had this language not been in the bill. You're looking at individuals sitting, languishing in emergency rooms, and not because the hospital doesn't want to provide the care, not because the mental health services center can't do it. It's just purely for the fact of this is what the course of business is. As an area agency, we contract with our community behavioral mental health center. We have a memorandum of understanding. We work very well with them. This would give us the flexibility and ability to do better work and to prevent people from having to languish in emergency rooms, to get them into the services that they need by having the support and medical interventions that are necessary. We're lucky. My region is we have a very good community mental health center. They work with us. They are the system itself, and to Representative McKay's point of view, they're overtaxed. They don't have the funding, and they don't have the manpower to really even meet the needs that they have right now. But what this does is it uncuffs us, allows us to work hand in hand to be able to provide the services that need to be provided, so that we can close this gap and move forward. There's some other language that's being suggested in the stands, the best way I can describe it. I would suggest keeping it simple so that the greatest amount of people can be included into this bill. because we have individuals with developmental disabilities, intellectual disabilities, or, just different varying challenges, trauma from brain injuries. Um, um, there's just a lot, and the list could be endless. You could exclude someone inadvertently or not. Um, so I would just caution that you keep it as broad as possible. But thank you.
Thank you. Any questions? Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. I absolutely love my job because all my patients are tweeners. They don't fit into cubby holes, and that's basically why we're creating models of integrated care, which I think may be a solution to this. But I really struggle with that first paragraph, and I wanted your opinion. I really don't think it's necessary to strike out. I understand why you want to do it, but I think it's a mistake to strike out the intellectual disability. But I would really rather focus on that last line of paragraph 2. That you can't. I think it's sad that it needs to be in there, but I understand why. The comorbidity point, you can't deny people, and I'm just curious what you think about that.
I think you should strike the verbiage. And I speak from a practical standpoint. The majority of my job is fighting with people, which is great because I'm contentious in nature. So, but realistically, fighting with hospitals, fighting with, whoever. And sometimes it's fighting with the hospital to fight with someone else in order to get the care so we can get them out of the hospital. Which, by the way, I say this, but I want everyone to be very clear in my opinion. The New Hampshire has one of the best hospitals and associations in the country, and I've worked in a lot of different states. I love my partners. We just vary on different subjects at different times. But they are great to work with. It's just, we're all very strong-willed people. But not having that verbiage in there would be a significant benefit to this population. And it doesn't seem like it's a very large change, and I can understand why you would want to keep it in there. But I can tell you, it's the people you deal with on a day-to-day basis. This is where they get triggered into taking these indefensible positions. And it will take me 3 to 5 days to get to the right person, who then will come in and weigh in and say, we should do this or shouldn't. Or it'll take another 3 to 5 days beyond that person to get to maybe the CEO of the hospital or maybe the CEO of the mental health center. There's a lot of built-in unnecessary waste, delay, and time. And if we can get in there, get the stabilization services necessary, we would probably prevent a lot of people from languishing in emergency rooms. We'd prevent a lot of people. I mean, one of the states that Attorney Sanic didn't mention was Florida. We sent a lot of people to Florida. And if anyone was watching New Hampshire Chronicle, here's my plug. We were able to get a person that was in a hospital for 2 years out of their emergency room. It took us a year to save for the home. We had to buy it. We had to staff it. We had to get it all fitted up. We can work to get all this stuff done, but roadblocks need to be taken out of our way.
Follow up.
So are you suggesting that this verbiage will no longer allow certain people to stop? They can't pass the buck anymore.
Essentially, that's been my experience. Other people may have varying experiences in communication. That's why I make the disclaimer: this is my region alone, and only me. And again, I can't express my gratitude for the partners that we have. We have a great system of mental health care. We have a great system of health care in our state. This just is a crack that we need to fill, and it's a very easy one, in my opinion. So,
Representative Weber.
Thank you. I keep looking at the words here, and the more I read, the more I see. So, looking at lines 19 through 21, I took into account the suggestion of taking out the double negative and having that read, an individual shall not be denied services under this chapter on the basis of co-occurrence. And it says mental illness, and it does have an intellectual or developmental disability already in there, although it's not in the upper part because it wasn't there to begin with. My question is, do we need to add the acquired brain disorders in there?
So
Or am I just making things too complicated? I know you started out by saying keep it simple.
No, if as you get to know me better, I love to overcomplicate things. My problem is I have not personally had the experience with
Okay.
an ASD person acquired brain disorder or ABD person with trying to get them services.
Okay.
But I've heard of issues, and I bring that up, but I don't want to color that was someone else's. Like, I don't want to speak for any other regions. Let me be very clear of that.
Okay.
So I guess strike that part of the testimony. I'm sorry.
Fair enough. Thank you.
Other questions? Seeing none, thank you.
Thank you all.
Also signed up to speak is Creighton Ward from Able, New Hampshire. And you've asked for 3 minutes.
Hi. Thank you, Chairman McDonald and Representative Bernardi. My name is Creighton Ward, and I am speaking on behalf of Kristen Evans, who is the Director of Policy and Advocacy for ABLE New Hampshire. ABLE is a disability justice organization, and we are a nonpartisan, nonprofit organization that fights for the civil and human rights of children and adults with disabilities. As a disability justice organization committed to advocating for the rights and inclusion of individuals with intellectual disabilities, we strongly support House Bill 1028. This bill is a critical step towards addressing the systemic barriers that individuals with intellectual disabilities face when accessing mental health services in New Hampshire. Currently, the exclusion of intellectual disability from the definition of mental illness within the state's mental health service system perpetuates discrimination and denies individuals with co-occurring intellectual disabilities and mental illnesses access to vital supports and services. This exclusion not only contradicts established research, but also undermines the principles of equity and justice. Research consistently demonstrates the high prevalence of mental health conditions amongst individuals with intellectual disabilities. According to a study published in the Journal of Intellectual Disability Research, the prevalence of mental health disorders among individuals with intellectual disabilities is significantly higher than in the general population. Furthermore, individuals with intellectual disabilities often experience unique challenges in recognizing and expressing their mental health needs, which makes access to appropriate services even more critical. Denying individuals with co-occurring intellectual disabilities and mental illnesses access to mental health services not only violates their rights, but also perpetuates cycles of poverty, isolation, and institutionalization. Without adequate support, individuals with intellectual disabilities are at increased risk of experiencing homelessness, involvement in the criminal justice system, and other adverse outcomes. House Bill 1028 represents a crucial opportunity to align New Hampshire's mental health service system with the principles of inclusion and equity. By removing the exclusion of intellectual disability from the definition of mental illness, this bill affirms the inherent worth and dignity of all individuals, regardless of their cognitive abilities. It ensures that individuals with co-occurring intellectual disabilities and mental illnesses have equal access to the supports and services they need to thrive in their communities. In conclusion, we urge that the members of the committee support House Bill 1028 and take a bold step in support of disability, equity, and inclusion. Thank you.
Thank you. Your pink card indicates you have handouts. Did you have handouts for the committee, or?
Yes, I do. I can
Okay.
hand them out.
Sure, you can just start them around, that's fine. Are there any questions? Representative Shapiro.
Thank you, Mr. Chairman. I'm going to ask you the same question I asked before, because I think you said that as written now, this excludes people with intellectual disabilities from people identified as with mental illness. And does it exclude people with intellectual disabilities, or does it just say that people who are primarily affected whose impairment is primarily caused by an intellectual disability should not be considered mentally ill, only if they have a co-occurring disorder of mental illness and intellectual disabilities.
Thank you, Representative Shapiro, for your question. I'm here on behalf of Kristen Evans, the Director of Policy at ABLE New Hampshire, so I would prefer to share your question with her, and maybe she can get back to you via email or something. Her email address is kristen@ablenewhampshire.org, so that's KRYSTEN at ablenh.org. So I've written down your question, and I really appreciate you asking that, but I'd prefer to forward it along to her. And I would advise the same to anyone else who's got questions for ABLE New Hampshire.
Thank you very much.
Thank
Okay,
you.
so you'd prefer no more questions at this point?
Yeah, I can't take questions
Okay, that's fine.
personally. Sorry.
Okay, thank you for being here.
Thank you.
Also signed up to speak is Julie Lego. Good afternoon.
Good afternoon.
And again, consistent with the others, I'd ask you to keep it to 3 minutes. You've indicated you wanted 4, but if you could keep it to closer to 3, that'd be great.
I will do the best I can. Good afternoon, respective members of this committee. My name is Julie Lego. I am a resident of Seabrook, New Hampshire, a proud social worker, educator, and a family member and lifelong friend of many incredible individuals with intellectual and developmental disabilities. I have worked in various capacities in the disability field for the past 24 years, most recently since 2012, specializing in clinical services and multidisciplinary team program development for those with intellectual and developmental disabilities and acquired brain injuries and co-occurring mental health needs. For several years, I have presented locally and nationally on topics related to equal access to mental health care for those with IDD and brain injury. I join you today in support of HB 1028 and say my career may have come by choice, but my path was one of necessity. In 2000, my friends and family members with disabilities and I experienced a series of several unexpected events. At the time, I was encouraged to seek therapy to support my adjustment through such significant loss. However, my cousin was unable to access therapy to process the loss of her mother. My friend was unable to access a therapist to support the tragic sudden passing of his brother. And my 2 friends, who were sisters, were unable to access mental health supports to address the loss of their brother from the very same genetic condition that they knew would someday, and have since, taken their own lives. All had limited access because of the presence of their disabilities. This was unfair during their times of devastation and truly discriminatory as they continue to struggle with access to mental health care in the years to follow. In my career as a New Hampshire licensed social worker, it is my mission to ensure that all people, regardless of ability or disability, have equal access to mental health care, including informed assessments from trained professionals. In my clinical work, I have supported hundreds of individuals with co-occurring intellectual disabilities, brain injuries, and mental health needs. I have received multiple calls monthly, and sometimes even weekly, requesting advocacy support in accessing mental health services due to being denied based on primary diagnosis. According to the National Association of the Dually Diagnosed, 35% of those with intellectual disabilities experience mental health needs as compared to roughly 20% of the general American population. For those with IDD, co-occurring mental illness is around 40%, with persistent mental illness around 30%. Those with IDD are 3 to 6 times more likely to experience abuse, neglect, or exploitation, while the majority of those with IDD experience trauma in their lifetime. I ask you to take that in. It is our responsibility to stop requiring a focus on primary diagnosis and allow for our clinical communities to foster a whole person approach to care. It is imperative that all individuals, regardless of a developmental diagnosis, have access to mental health assessments and are supported from a whole person approach to care. All of us have our primary needs change based on our mental health symptoms, daily stresses, etc. We cannot determine what came first, the chicken or the egg.
Yeah, if you could please start wrapping up.
Yep. I ask that we hold our mental health community responsible for supporting all people as people based on their presenting needs. I urge you to vote in favor of HB 1028 to support the necessary steps in moving towards a community that supports equality and mental health services for all New Hampshire citizens. Thank you for your time and consideration.
Thank you. Any questions? Representative McKay?
Mr. Chairman. I'll try again. You seem to have extensive experience. Is there special training that's different from the training for people who treat mentally ill patients? Because it sounds as if what you're saying is that the mental health system is not supportive of individuals with intellectual disability. Can you define what an intellectual disability is? I think I know, but can you help us that way?
Absolutely. So an intellectual disability is something that is experienced within an impairment experienced within the developmental age. I could get into the DSM and all of the criteria, but I think that would be a longer conversation than we certainly have time for. However, to go to your question about training, Attorney Sanok mentioned about the DMID2. That is published by the National Association of the Dually Diagnosed, where I've had the pleasure of presenting at some of their national conferences in the state of Ohio a couple of times. That should be, in my opinion, the standard of care when providing mental health services and diagnosing of mental health conditions for individuals who experience intellectual and developmental disabilities. It speaks to it compares the criteria of our diagnostic tool of the DSM-5, which we use, I'm sure you're familiar from the medical field, but in mental health, we use the DSM as our diagnostic tool. The DMID takes into consideration presentation that would come from an intellectual disability, and it provides a comparison to ensure that we're taking everything into consideration. It helps prevent diagnostic overshadowing, and that's what we see in our population over and over and over again. We label people based on diagnoses. It's the intellectual disability. It's the brain injury. However, our statistics tell us that people are people, and people with intellectual disabilities are statistically more likely to experience mental illness than their neurotypical peers. We have the right and responsibility to diagnose with the appropriate tools, be trained on those, and then also have trainings, and I appreciate you asking, further trainings for our mental health professionals to broaden our skill sets so people aren't excluded based off of talk therapy alone. My most beneficial sessions sometimes have been sitting on the floor and providing therapy, and we do what it takes for our individuals.
Thank you. Representative Nagel?
Thank you, Mr. Chairman. Thanks for taking my question. I really appreciate your testimony.
Thank you.
I have a concern that you raised that it kind of reflects what I was talking about earlier in terms of striking out intellectual disability and including that as a mental disability. My concern now is that that will suddenly become an Axis 1 diagnosis. And wouldn't that have the unfortunate side effect of saying that, oh, you have an intellectual disability, we don't cover that, we only cover psychiatric diagnoses. So I'm afraid that that change will actually exclude these people using DSM criteria.
My very, very genuine hope is that striking the language of intellectual disability, if we do not, if I'm interpreting this correctly, and I want to pull it out to make sure that I'm seeing the same thing you are.
Yeah.
Where it states it does not include impairment primarily caused by. The words primary impairment scare me. They frighten me to my core as a clinician. There is a significant, and as a family member, to be honest, and I want to be very clear that I am sitting here not only as a professional, but the first hat and the most important hat I wear is a family member and an advocate. I fear the discrimination that will continue if we allow people to be labeled by a primary diagnosis, because that is nearly impossible to provide. To say what came first, and so I'd like to say that if we were to not strike that language, it is going to allow people to continue to be discriminated against based on disability, and withhold the, or possibly withhold the ability for them to even access initial assessments that may, those initial assessments are imperative to identify, do they have a severe persistent mental illness? Do they qualify for services in community mental health or at mental health centers? I urge you to maybe think about somebody who experiences autism and schizoaffective disorder or a psychotic disorder. One of the people that I have treated for a very long time, I can't tell you what's primary for that person. On any given day, on a very great day, and that person's taking their medication, he's doing fabulously. In autism, probably primary that day because he's stable, he's getting all of the services he needs. He's getting wraparound services, medications are going well, and he's an active member of and valued member of his community. However, when medications are not stable, if he's not consistent in services, his symptoms of schizoaffective disorder or any other psychotic disorder will amplify, they'll exacerbate, and in that moment, that is his primary impairment in functioning. I can't tell you what's the overall in his life primary impairment in functioning. We have to treat them equally, and we need to treat people as people.
What's that?
I think so.
Representative Merchant.
Thank you, Mr. Chairman. Also, thank you for taking my question. As I listen to these conversations, I'm actually more concerned now than I was before. When I think of autism, it's sort of a spectrum.
Mm-hmm.
You can have somebody very high functioning on autism and somebody on the other end who's not.
Mm-hmm.
Is not epilepsy the same way? There are people who have epilepsy who are on sort of a spectrum too. There's all forms of epilepsy. There are some epilepsies that really cause tremendous emotional disturbance for a child, sometimes an adult, to the point where they cannot learn effectively and so forth. So why are we leaving epilepsy in there and not dealing with that one at the same time?
That's a very valid question. My experience as a professional in Loveland is in the area of intellectual and developmental disability. I do not have the background or education per se in the medical field, which I do feel epilepsy would be more in the realm of the medical. So I would be remiss to speak to that directly. Medical conditions certainly have an impact on mental health. I see that every single day. I can tell you that when my kids don't feel well, their mental health changes. When I don't feel well, my mental health changes. That is certainly valid. However, because I can speak to my expertise in intellectual and developmental disability, this is something that we have seen as a stigma that has occurred since, well, really forever. It comes from that period of institutionalization where we have been told as long as my colleagues and I can remember that people with disabilities, the language has been used, people are too disabled to have mental health needs. They're too disabled to feel those mental health needs, and we know that is not true. So I know that I'm certainly going on a tangent separate from your question, but I can speak to my area of expertise, and I'm sorry that I can't speak to the medical, but we do have a responsibility for these individuals who experience intellectual disabilities and autism and brain injury to advocate to decrease that stigma.
Other questions? Representative Nagel?
Thank you, Mr. Chairman. I figured out what I wanted to ask, and I would thank Representative Merchant for helping me. So my psychology's old,
That's okay.
but it's been a large part of my career. I don't use the DSM regularly, but my understanding is that when we make mental health decisions, we're focusing on Axis 1. And so, like, we can put autism and epilepsy and all those other things in Axis 3, but those people commonly have mental health issues as well. So in making these decisions, you're using the Axis 1 definition, and we're basically, they're saying, well, we're not going to pay attention to the Axis 1, we're just going to say we're going to treat you because of the Axis 3. My concern is that, getting back to what I asked before, if we strike out intellectual disability, all of a sudden now we're promoting intellectual disability to an Axis 1 diagnosis, and they can just say, no, we're not going to treat this person because we only treat psychiatric illnesses. That's my concern, is we're going to make a bigger problem than we've got now. That's my big concern.
I do hear where you're coming from. I would argue that from my perspective, I feel there is no bigger problem than blatant discrimination. And I do feel that in the language that is here right now, there is blatant discrimination that indicates that it will not include people primarily diagnosed with an intellectual disability. And that says to me, not you, not your loved one. And we need to have people be able to at least access appropriate assessments so determinations can be made. This language, as it stands, prevents people from appropriate assessment, and that is quite dangerous from my perspective.
Other questions? I'm saying none. Thank you.
Thank you so much.
Also signed up to speak is Karen Turner. Good afternoon.
Hello.
Once again, you've asked for 5 minutes. If you could keep it to 3, I'd
I'll
appreciate it.
try. I mean, I prepared this testimony all day yesterday. I'm the parent of what the CEO of Wesley said is the poster child of this problem. I just want to, if I do my job correctly, everyone here will see the obvious need to strike intellectual disability from the language of the statute. Because my son is dually diagnosed with autism, some intellectual impairment, so intellectual disability and mental illness. And I was told that by a psychiatrist, and it's been my experience, that people have a hard time understanding his autism looks really different because of trauma that he experienced in his anxiety problems. Makes him look more autistic. And his trauma, his mental illness looks a little bit different because he's autistic, and it just manifests differently. And you can't really parse out someone's brain and say, this is, it's 40% autism or something. So I'm just going to read my statement. I'm the parent of a 24-year-old son who is intellectually, developmentally disabled with co-occurring mental illness. His designation as intellectually disabled leads to the denial of mental health treatment no matter how hard I try to get him access to mental health services. My son has experienced psychiatric crises which have led him to hospital ERs numerous times, including Portsmouth Regional Hospital, Wentworth Douglas Hospital, Exeter Hospital, Elliott Hospital, Concord Hospital, and even a hospital in Massachusetts. Each time his crisis is triggered by obsessive worries and stress. Despite diagnosis and documentation of his mental illness, he is diagnosed with obsessive compulsive disorder, and incidentally, about 20% of autistic people have OCD. My son has been denied access despite diagnoses. The reason, because he's autistic and considered intellectually disabled. I hope not to offend you when I say that it feels like he's being punished continually for the crime of being an autistic person who happens to also experience mental illness. I see that the state settled a lawsuit over acute mental health patients being held involuntarily in hospital emergency departments awaiting treatment. My son's situation and that of other individuals with intellectual disabilities in psychiatric crisis is even worse. They don't even get deemed eligible for mental health treatment. They board in the ER without any treatment by the doctors or mental health clinicians, nor any help to know what the next step would be, nor any guidance from staff as to where they go to get assistance. This is a very scary situation for the patient and their family. It caused my son great confusion and pain to be stuck in the emergency department, to see other people seeing mental health counselors, and they, even when I asked, they would refuse to even see him. Even though when he was there for weeks and months at a time. My son sits for weeks, other times months, waiting indefinitely. So in 2022, he was a month in Concord Hospital Emergency Department, and in 2023, he was 2 months in an emergency department at Elliott Hospital. And both times it was refused, a mental health clinician, and so I speak from this personal experience.
Ma'am, you seem to have quite a statement there, but could you start wrapping up, please?
When my son was boarding at the ER, one of the doctors paused the Zoom meeting to say, "We are complicit in this torture of patients by engaging in a broken system." During another time boarding in an ER, a different doctor said it's a tragedy that people like my son don't get the mental health treatment that they need. He'd be too safe to return home without the treatment, but then nonetheless cleared because he's autistic. He was literally never deemed eligible for mental health treatment. He was even threatened by a hospital to be taken to a homeless shelter when he was boarding. I don't know if you can imagine how much you would suffer as a patient if you were in psychiatric crisis, feeling unworthy and ashamed that you can't control your symptoms by yourself, only to be told you have behavioral problems you need to control. In the meantime, you will be left alone, sitting in a room by yourself for weeks.
Again, please start wrapping.
Sometimes
Please wrap up. Ma'am.
months without a chair to sit in. This is my son from last week that I'm talking about. You kind of threw me off. Can I just at least get to my highlights? I prepared.
Well, yeah, but please conclude, though.
Okay. Okay. Hospitals across the state have dismissed his mental health crises. My son hasn't been able to access outpatient mental health treatment either through the mental health system. This is what he needs treatment in order to prevent these crises in the first place. Riverbend Community Mental Health justified their denial of therapy for his mental illness, categorizing him as a low service utilizer because he has an intellectual disability and is getting services through the Bureau of Developmental Services. But they don't treat mental illness. They do nothing for mental illness. He can get medications, psychotropic medications, for psychiatric illness without any problem. He's on a lot of them, but he can't get actually therapy, which is, everybody knows in the field that it's a combination that helps people get better. You can't just give people drugs. In October 2022, my son was living in Concord in a model called Enhanced Family Care, which is like foster care, and he had been thriving enough because when we couldn't get the mental health system to provide the treatment he needs for OCD, my parents, his grandparents, paid for out of pocket for about a year. And he actually got better and stabilized, wasn't going to the emergency department, was actually able to take a trip to go to Pittsburgh, where his hero, Mr. Rogers, is from.
Ma'am, please.
And then October 2022, I'm going
to have to ask you.
Okay, one of his providers attempted suicide in the house while he was home, and it caused him to feel suicidal, and he took himself to the emergency department, and they dismissed his suicidality because he's autistic. And then he attempted suicide the next day. It was sent back there and went boarded for a month, and still wasn't considered eligible even after a suicide attempt, and even after having to be restrained in the emergency department, they just wanted to send him home, but there was no home to go to because he wasn't really safe. So what's happening is some
Ma'am,
people
please.
can I just
Well,
finish up,
hurry,
please?
please. You're way over your time.
Okay, well, I appreciate it because it's like I feel like it's really
Because
important.
you've gone over the 5 minutes you've asked for, actually. Yeah, I mean, maybe.
Okay, well, I just want to say that individuals like my son, who are either like autistic or intellectually disabled, they have higher mental health needs, and
We
and I'm
understand.
saying it's a major barrier. And the other thing I want to say is, no one's mentioned this, so I think this is really important. Let's just talk real. What gets people's attention is behavioral problems. Someone's acting unsafe. Someone's a danger to other people, and they can't regulate their stress properly. And that's what happens, and that's what gets them there. The problem is the language in here makes it easy for the hospital, which they always say that it's agitation, he's having a temper tantrum, even though it's well documented he has severe trauma, OCD, and anxiety problems. They just don't want to deal with it because he's autistic, and it's caused him
If
to
you
be
could
forced out
email
of
your
the state.
statement to us, please, ma'am.
Yes, and he's been forced to live out of state. He's a high school graduate.
Does anyone have any
and-
questions
and
for this
he
lady?
has worked and volunteered in his community, and now he's forced out of state in a group home away from his family, like only because he doesn't get mental health treatment for being autistic. Thank you very much for
Thank you.
for listening.
Any questions? Okay, thank you for your testimony. And again, if you're welcome to submit that to us online if
I
you'd
did
like to. also.
I did bring some copies, but I don't
Okay,
think I
that's
have
fine.
enough.
If you want to send them around, that's fine. Also signed up to speak is Chelsea Zarconi. You've asked for 3 minutes.
Thank you for giving me the opportunity to speak here today. And good afternoon, representatives and valued members of the community. As stated, my name is Chelsea Zarconi, and I am a lifelong resident of New Hampshire, a very proud 603er. I'm here today both as a concerned and passionate citizen, as well as a licensed social worker and certified brain injury specialist in support of HB 1028. I have been supporting those with co-occurring mental health needs, with developmental disability, and/or acquired brain injury for a decade. But really, I've been doing it since childhood. I grew up with a friend who was living with cerebral palsy and struggled to gain inclusion to care and access to services the way the rest of his classmates had. As I've continued through my career, I've become privy to significant gaps in service delivery to those living with disabilities, specifically gaining access to support their mental health needs. I speak with family members, survivors of brain injury, those living with developmental disability, and fellow professionals with consistency regarding the discrimination that people experience on a daily and weekly basis in all facets of care across all settings. Those living with co-occurring diagnoses deserve the same level of access to care as their neurotypical peers, as it is their basic right. A primary diagnosis of developmental disability and/or acquired brain injury does not exclude someone from experiencing severe mental illness and requiring specialized and informed care designated by their mental health professionals, which is not the responsibility of the area agency. Regardless of our stance, political views, or backgrounds, we're all in this room because we want better for New Hampshire residents in the state we love. As a social worker and human, it's my ethical and moral imperative to ask today that HB 1028 be passed, as it's a necessary step towards equitable access and towards this betterment. I ask today that you, the representatives and committee, consider that if somebody with a developmental disability and brain injury is not discriminated having this diagnosis, why should the mental health care discriminate against them? And to your point, Representative McKay, our system has come a very long way, and I'm very proud of that for our state. And the ask for this bill is just to continue to push it forward. Thank you.
Thank you. Any questions? Representative Weber.
Thank you. As a brain injury specialist, maybe you're the right person to have asked the question. If we pass the bill as it was submitted to us, does it sufficiently cover the population with brain injuries, or do we need to add that as a specific?
I would say adding it in specifically. And the reason I say that is because a developmental disability, which includes IDD and or autism, is something that somebody has, as previously stated, in their developmental age. However, anybody, any of us in this room can experience a brain injury at any time. And the reason I also highlight it is that individuals with brain injuries are also served specifically by their area agencies.
Could I have a follow-up? And as a
Follow-up?
Thank you. And if I may follow up, what is the specific technical term that you would recommend? Because we've said brain injury, we've said acquired brain disorder, and I am without the technical knowledge to understand which of those formulations is the correct one.
Yes, it's a very good point. I would use acquired brain injury or acquired brain disorder. And the reason that I specify acquired brain disorder is that the ABD waiver, which is something that people with an acquired brain injury, there are specifics around it. However, it is something that area agencies also offer. So if we're looking for that continuity, that is language that area agencies use.
So acquired brain disorder.
Yes.
Okay,
As
thank you.
it encompasses acquired brain injury as well.
Okay, thank you very much for that. That's
Thank
very
you.
helpful.
Representative Merchant.
Thank you, Mr. Chairman. Also, thank you for taking the question. Earlier, I asked the question about the diagnosis of epilepsy.
Yes.
And that also, in a lot of ways, like autism is on a spectrum. Can you address that as far as whether we should try to deal with it? It's not a brain injury per se, it could lead to one, but most of the time it's not the issue. However, severe epilepsy, particularly in some children, can cause problems emotionally and otherwise.
Correct. And I would not disagree with that at all. My epilepsy, as dementia, I know was mentioned earlier, there's so many neurological disorders that fall into their own category. What I would be able to extrapolate from somebody likely living with epilepsy is that they are going to experience psychosocial challenges, therefore experiencing higher need for mental health care. Further, I would say that removing any sort of discriminatory language from a bill doesn't do anyone any harm. So being able to provide access to care to any sort of co-occurring mental health, and whether it's a physical or cognitive disability, is just allowing further exclusion to care for people.
Representative Seth King. Oh, I'm sorry, follow-up?
Thank you, Mr. Chair. So following up on the terminology, which I think is going to be critical here, in saying that, is it neurological?
Epilepsy?
No, just saying neurological disorders to some degree, because that's what we're really trying to get to with it's going to be brain acquired disorder, epilepsy, autism that causes interference. That's what we're trying to get to because it's neurological in nature, all of it.
So although I'm a certified brain injury specialist, I cannot make neurological diagnoses. I can make diagnoses under the DSM or the DMID. However, epilepsy really falls into a medical category. So I can't really speak specifically to what you're asking. Again, I don't want to step out of my role on that. However, I would wager to bet, again, as anybody living with a co-occurring disorder is probably more likely, or just likely in general, to be experiencing some mental health needs at the same time.
Representative Seth King.
Question for the chair. I don't know if now is the best time to bring it up or not, but Representative Merchant has asked a question a couple of times that I also was wondering myself, and I suspect others were as well. And I talked to Christina, and I wanted to know the history of A, B, C, and D, and why they were put and when they were put in that paragraph. And she said, with your permission, she could get started on that. So that might help elucidate a little bit what's going on there, because I felt like these just seem shoehorned in to something that was originally there, and I'd just like to know the history. So
Sure. Yeah, Christina, if you could do that, that'd be great. Thank you. Any other questions? Seeing none? Okay, thank you. Also signed up to speak is Chris Close enough. Thanks. You know who I'm talking about. And again, you've asked for 5 minutes, sir. If you could keep it to 3, we'd appreciate it.
Okay. My name's Chris Tagakis. I have a son,
Kevin, who's 30 years old, who's profoundly autistic. This is a little snapshot, and within its context, this bill is. Kevin is an essential part of his community. Since leaving high school in 2014, Kevin has had a productive day and home program. He had a summer job at Home Depot for 4 years. He volunteered at Meals on Wheels for the last 8 years, delivering meals to the homebound clients 5 days a week. He had a gym membership at the YMCA, where he would swim laps and use the wellness center. He visited local restaurants, supermarkets, and stores throughout his community. He kept to his schedule throughout the COVID pandemic. People always know Kevin by name wherever he went. At home, he was always eager to help when asked. Mid-January 2023, we brought him to the Elliott ER with concerns of increased aggression, self-mutilation, and strange body movements. We were told by an ER doctor they do not admit autistic patients into the hospital for psychiatric treatment. At the end of January, we wrote an email to Community Bridges stating that Kevin was in crisis and we were in need of support. We were seeing more destructive behavior, including damage to the house, self-mutilation, and violence toward caregivers at home and in the community. We were unable to bring him out into the community as per usual of his day program, and that we did for the last 8 years. Community Bridges and Sarah Beamish from Elliott Behavioral Health recommended that we call the Mobile Crisis Response Unit to get an IEA, involuntary emergency admission placement for Kevin. On February 12th, the Mobile Crisis Unit came to the house with the Ware Police Department and decided that Kevin did not qualify for an IEA placement because of his autism. On February 15th, we visited Kevin's PCP with our concerns. While in the office, Kevin attacked his mother by punching her in the chest. No real guidance was offered, and we were sent home. On February 16th, Kevin became increasingly violent. He was hitting and kicking his mother, as well as slamming his body into the slider. Kevin's mother called me to make me aware of the situation. I called his primary care physician, who recommended that we bring Kevin to the Elliott emergency room for evaluation. We called 911, and the Ware Police Department arrived at the house with an ambulance and brought Kevin to the Elliott Hospital emergency room in Manchester. The emergency department staff placed Kevin in psychiatric evaluation placement, PEP unit. That is a PEP unit in the emergency department, not the hospital proper. After several hours at the PEP, they decided that it would be detrimental for him to remain there because of his aggression and violent behavior, and asked that we bring him home. I felt it was unsafe for Kevin to be at home, and it would also be unsafe for other family members if Kevin were at home. After several days of being observed in the PEP unit, they still refused to admit Kevin into the hospital for treatment because of his autism. They also cited a law titled RSA 135-C(2), which states that anyone with an intellectual disability is expressly excluded from mental health services because there is a presumption that any atypical behavior is caused by the intellectual disability. Elliott Hospital stated it is the responsibility of the community to find a safe place for Kevin. The state, through Community Bridges, declared it was not their role. The hospital and state went back and forth, declaring that neither one knew the other one's role. I demanded a resolution as his advocate. A social worker at the Elliott Hospital and a supervisor at Community Bridges both recommended that Kevin go to the New Hampshire Start Center. I agreed to this because Kevin was in crisis and our family was under duress. The Start Center turned out to be a respite facility for adults in transition crisis. The staff at the Start Center had no expertise with autism and didn't have the ability to make any psychiatric or behavioral evaluations that were not provided at the hospital.
If you could start wrapping up, sir.
As his caregivers and advocates, we continue to seek out supportive services for behavioral and mental health for Kevin. Kevin's behavioral Health sent a referral to Riverbend Community Mental Health Center in Concord. When we contacted them, they informed us they could not accept Kevin as a patient due to his lack of communication skills. Because he is severely autistic and nonverbal, they could not take him as a client. Additionally, excuse me. Additionally, we sought out intensive treatment services which are provided for high-risk adults with disabilities in New Hampshire. To qualify for these services, it requires Kevin to be identified as high risk. We sought out a risk evaluation and the state wasn't able to provide one. He was denied access by a statewide committee called the Community of Practice. They stated they needed documentation which shows that Kevin's behavior is not rooted in a medical condition. They said we do not have sufficient documentation of this. We also put in a referral for applied behavioral analysis for Kevin. We have been waiting since August for financial approval from the BDS to start this service for Kevin. Community Bridges has supported and not resisted policies that deny mental health rights to Kevin. Policies that withhold services until he commits a crime, and that is nothing less than entrapment. Participating in the entrapment of a vulnerable person represents a frightening culture of misplaced public trust and unchecked authority. Authority and trust unencumbered by self-analysis or sound ethical judgment is unacceptable. There are no emergency crisis services for the profoundly autistic. The START Center is not an emergency service. One must undergo an initial intake process. It is not an in-house psychiatric treatment center. The emergency rooms in our hospitals would not admit profoundly autistic people into the hospital, and they openly say so, citing a law entitled RSA 135-2C:2. A committee associated with Community Bridges,
Again,
known
if
as
you could wrap
Community
up,
of
please.
Practice, 2 pages, determined that there was not enough documentation to place Kevin in intensive treatment services. They made this determination despite an extensive PEP report from the Elliott Emergency Room, years of evaluations, IEPs from various educational and medical professionals, comments by his PC, and numerous reports from us as parents. We asked Community Bridges to connect us with a risk assessment. We have been waiting for many months for the documentation that the Community of Practice Committee had asked for. We are still not being provided a risk assessment, despite the state providing no dissenting views, reports, or evaluations to counter the paperwork that the COP rejected. The only substantive request was that we provide medical documentation showing the behaviors are not a response to a physical condition. Since then, Kevin had an endoscopy, a CAT scan, blood work, EEG, ultrasounds, and an MRI. All of these came back normal, and still there is no response
Please
from the
wrap up.
state, its agents, and vendors. We put in a proposal for a behavioralist consultant back in August 2024. We asked for 4 months until a more complex service could be provided. We never heard anything about this being approved. In October, we requested a more complex program, was just approved for a mere
Sir,
26
please.
hours. I'm on
Please.
my last page.
Well, is it a full page or how long?
It's 3/4 of a page. It's
So
a year
we-
if it's a year of suffering, I'm going to take it.
Well,
Forcing parents and caregivers to be self-educated doctors, educators, behavioralists, and psychiatric treatment facilities for a vulnerable person who the state, public, and private sectors openly reject is nothing more than state-sanctioned neglect. The state has not produced any private facilities that can properly treat and facilitate a stable environment for Kevin. There is no state-run group homes that provide services. The state has no plans to procure, produce, or seek to facilitate the connecting of such services. They simply put Kevin in a pool of people to linger in perpetual condition of state-sanctioned neglect while the crisis in his life unfolds. Furthermore, I have been told on multiple occasions that it is out of the scope of area agencies to provide mental health and behavioral services. Simultaneously, it has been determined that it is within the scope and authority of community to practice to deny the same. This is a double standard. Like entrapment of vulnerable people and state-sanctioned neglect, double standards are not ethically tenable. Thank you, Chris DeGagas.
Okay, thank you for your testimony. All
Any
set.
questions?
I'm seeing none. I think you covered it pretty well.
I don't know if he wants to submit the written testimony. Or did he? I'm sorry if I missed that when I was coming in from another meeting. My apologies.
Anyway, in terms of the blue sheet in the back, 10 people signed up in favor of this bill. The department signed up and it took no position. And on line 12, signed up in favor, 1 opposed, and 1 neutral. With that, I am going to close the public hearing on House Bill 1028 and open the public hearing on House Bill 1615 FN. And recognize the prime sponsor, Representative Eric Gallagher.
Hi, so, since it kind of took a while with the previous one, I had to go out to, plug in my computer to charge out in the hallway, so do you mind if I run and go get that
Oh,
real quick
go ahead.
before starting?
Sure. Oh. Yes.
All right, so,
Representative Gallagher, you may proceed.
yeah, so I'm Representative Eric Gallagher, representing, Merrimack County District 20, which is Concord Ward 6, and I'm here to, present HB 1615 relative to the autism registry. Um, so, um, yeah, so that previous bill, since I was here listening for it, has kind of made me a little bit wary about the terminology I use here when introducing this. But personally, the term I prefer to use to refer to myself is that I'm a member of the neurodivergent community. So I don't actually have autism myself. I've tested negative for it multiple times, which, yeah, may have you thinking, oh, well, maybe he does have it. And you know what? Fine. I don't care if you think that. Just know that it's not what I think I have, and it's not part of my diagnosis. But anyways, yeah, you've got neurodivergence is kind of like a larger spectrum than just the autism spectrum. So being part of that community, I often hear people talking about different laws relating to different conditions within that spectrum. And one thing I heard about recently was finding out that we have this autism registry in the first place. So yeah, when I heard about that, I was kind of shocked to learn that it existed. Yeah, my first concern was, okay, we've got a state constitutional guarantee to a right to privacy. Does this registry comply with it? So I sent out a research request with OLS. They got in touch with DHHS. DHHS said that yes, it does comply. The rulemaking they sent, though, seemed to contain some information where I'm not entirely sure I'd agree that it supports their claim that it does actually protect privacy as well as it could. So I decided, all right, I'll just look at the enabling statute and see what I can change about it to improve the privacy about it. Yeah, to kind of go through the changes. So the first one, replacing epidemiologic with sociological. That's because one of my co-sponsors, when I was discussing it, Representative Fio, wanted to make it clear that autism is not a contagious condition, and epidemiologic kind of has that implication that it is. So we just kind of wanted to make sure that people understand that, like, it's not an epidemic. And then for replacing problem with phenomenon, a lot of people on the autism spectrum would think that their condition is not actually a problem and is in fact an advantage for them. That wording changes just kind of to destigmatize it a little bit more, kind of reduce the ableism here. So then the part where it says the department may enter into an agreement with an appropriate entity for the management of the registry. So that part kind of concerned me that, because that's basically saying that it's not just the state that has access to this registry, but also potentially a third party entity that could have access to it as well. It does say provided that any records and data submitted to the department pursuant of this division shall be the property of the department. But the thing I was worried about there, so one of my kind of pet issues is free and open source software, and open data formats. So, even if the department owns the records and data, those records and data still could be useless if you don't have the proper software to be able to read it. Imagine if the registry was kept in hieroglyphics and you didn't have the Rosetta Stone. Like that. So yeah, basically that's what the additional clause as well as the software used to store such data, why I think that the department, just to ensure that this third party entity can't change something about the format of it to make it unusable to the department. So the next section, so the next part is about what is in the actual registry. So I tried to reduce the amount of personally identifiable information that's in it. Date of birth kind of had to stay since, I'll get to that in the next section. Gender, though, I didn't really see a reason for including, and that's a additional source of personally identifiable information. So I thought of removing that. And then it mentions a unique identification code for identifying the child. So looking in the rulemaking, so apparently the code is based on the initials of the child in question. And so it currently says it shouldn't include the name, but to me at least, initials are still pretty close to the name. So I think it's worth specifying the initials separately. If the department could come up with some other sort of unique code that doesn't involve initials, come up with some sort of cryptographic hash or something instead. and just wanted to make sure that none of the other fields contained that information as well. So the next sentence, so one thing I did while researching this was to do a comparison of other states that have autism registries. And one thing I found that New Jersey's had that I think is actually kind of a positive aspect that's worth emulating is when someone's entered in theirs, they provide resources to the person who is and their family who's being entered onto it. Yeah, I added a sentence to provide for that provision of resources as well. And then, so since this is where the amendment I handed around comes in, also upon discussing this, one bit of feedback was why not add an opt-out mechanism to it? And that I thought that was a good suggestion. I honestly can't remember why I didn't include that in the first place. But anyways, yeah, I thought that the opt-out form, that this would be the proper place to put that, like right after with the provision of information clause. So in section 3, I think drawing an explicit reference to the state constitution's guarantee of privacy is, yeah, the department already has to follow it, but I think saying so explicitly is just kind of good as a reminder or a form of defense in depth, to just really drive home that this is something that we care about. So the addition of licensed or certified, so in on line 24, so that is if you go back to the beginning of section 2, where it says physicians, psychologists, and any other licensed or certified healthcare provider shall make this report. So the addition of those terms is just kind of to bring the wording in sync, and so it's in sync in section 3 as it is in section 2. Because the part in section 3 is basically a grant of immunity for divulging confidential information, which I can kind of see why that's necessary for it to be provided in the first place under section 2. But since the wording's different, or under current statute, what I worry could happen there is, it could allow, say, an unlicensed or uncertified provider to violate someone's privacy, even though they technically don't have to under section 2. So this is just kind of to tighten up that language there. And then the addition of section 5, whenever a child reaches 18 years of age, the department shall remove the entry pertaining to the child from the registry. Again, that comes from the comparison with the other states' registries. The other states that do have registries do mostly have age-out mechanisms, and it doesn't appear that our current registry has such a mechanism. And if you just look through the language of the existing statute, it is constantly referring to the child as the one being entered into it. So I think that kind of demonstrates that the original intent of this bill was specifically for children and not for adults. I think that changing this should help bring that more in line. That's basically what the bill does. To address some questions I received about it, one of the most common is, oh, well, why not just abolish the registry entirely? And I mean, that's something I'd be open to if that's the direction that members of the community want to go in. I was just feeling a little bit more cautious about it and think, okay, maybe there is actually a legitimate reason for having this, and maybe somebody will testify to that. I'm not sure, but yeah. So, well, one of my concerns that as to why not just abolish it completely is the part about the third-party entity that could potentially be administrating this registry. I'm worried that if we abolish it improperly, we might accidentally end up just abolishing the state's copy without also abolishing any copy that the third-party entity might have. So yeah, I just want to make sure that we have it fully under state control before abolishing it. So yeah, we can make sure we do it properly. So yeah, that's what I've got for now, and I'll take questions.
Any questions? Representative Weber.
My question is actually for the chair, and we've been piling a lot of work on Christina Dyer lately, but I would be very
She's still smiling back there.
I would be very interested in a history of this legislation because it actually, the registry came in 2006, which was the year that I was elected. So I have no personal history of why we have it or what we were trying to accomplish at the time. And I think that having the background would be very helpful for us, or for me personally, to
I think
understand
you just gave me a thumbs up, right?
whether the registry is accomplishing what we wanted it to do and why we might want to keep it or not keep it.
Yeah, and I agree that is something that I wasn't really able to find out much about myself. So yeah.
Representative Merchant, then Representative Seth King.
Thank you, Mr. Chairman. And thank you, Representative, to bring this bill before us. I concur with what you're saying. There should be a mechanism to withdraw any information out of a registry if the parent or if the child, upon reaching the age of 18, so desires to do that. So I'm fully in support of that. But I also concur with Representative Weber is trying to understand the history of this, and fundamentally more important than the history, is the registry being utilized, and if it is it effective, and is it accomplishing what it wanted to accomplish?
So this is something when with talking with one of my co-sponsors that apparently Representative Theo looked into a little bit. Apparently the point is for doing scientific studies with, I mean, and I think that's they kind of touch on that in section or Roman 1 with enabling analysis and facilitating planning and services. But yeah, from what I've heard is that hasn't actually been happening, is that apparently there's only been one peer-reviewed study that has used the autism registry's data since it was first introduced, which, yeah, that seems like a fairly small number and like it's not really living up to its purpose to me.
All set, Representative Merchant. Representative Seth King.
Thank you, Mr. Chair, and thank you, Representative Gallagher, for taking questions. I don't have a device in front of me to look up definitions. Anytime I have a question about definitions, I love to look things up just to really make things concrete. So maybe somebody else can do this and later explain to me. But you want to scratch out the word epidemiologic and replace it with sociological. And the reasoning you gave was that, autism isn't contagious. But I know that we often use the word epidemic for things like obesity, loneliness epidemic, and those aren't contagious. So I'm just wondering if either I or you are mistaken by what epidemiologic means. And then furthermore, you replace it with the word sociological, which to me sort of implies cultural, not terribly, that's not the best word, but it sort of almost sounds like it's a choice more than something that you don't have a choice in if you use the word sociological. I could be wrong about that. I'm just throwing that out there. What are your thoughts on that?
So yeah, I think there is a difference between referring to things as an epidemic and the use of the term epidemiological. I think when you add the ology suffix on there and, talking about it in a scientific context, that is different from without that suffix when, without that suffix, it's a lot, people are generally a lot freer to use it as a metaphor or as figurative language or something, but adding the ology kind of makes it not quite so much. My intention with sociological, replacing with sociological wasn't to imply that autism is a choice or anything like that, but just kind of to try to come up with a different adjective that's a little bit more humanizing for the people experiencing these conditions. If you have an alternative adjective that is better than both epidemiologic and sociological, I would be open to replacing it with that third adjective instead. But that is just the first one that came to mind for me.
Other questions? Oh, follow-up?
It's not a follow-up, but I do have another question. You have this part here, as well as the software used to store such data. Now, being a free software advocate myself, I know what that means, and I know you know what that means. I'm not sure if the lawyers would really know what that means, because it's not terribly explicit saying free software, which you own and you control and you could edit the source code and all those things. And my question is, so for example, Excel is a Microsoft program, I believe, and that's a spreadsheet. And free software advocates would use like I can't remember what the name of it is.
OpenOffice or
OpenOffice
or
OpenOffice, which is basically Excel, but it's free software. So if they had this registry, my question is, they'd probably be required to use something like OpenOffice instead of Excel. But seeing as how they're going to be on computers that are Apple or Microsoft computers, they're not going to be Linux computers. Would this get them in trouble? Because while OpenOffice might be free and open source software, the computer, the operating system itself would not be, and then it would really get them into trouble. What are your thoughts on that?
So my intent here wasn't necessarily to try to free the entire software stack all at once. I mean, that is something that I've tried with other legislation, but it hasn't gone over too well with the state IT department. So my intent here was to keep this limited or in the most narrow fashion to just the software, the program, individual programs such as OpenOffice or LibreOffice or whatever. And I'd also note that RSA Chapter 21R has some definitions of open data formats. So and open source software. So I think if you need some more precision, you could just draw a cross reference to RSA 21R10 to make that a little bit more explicit.
Other questions? Seeing none. Thank you.
Thank you.
Also signed up to speak is Representative Caitlin Kutab.
Thank you, Mr. Chairman and honorable members of the House and Health and Human Services Committee. For the record, I'm Caitlin Kutab, representing Rockingham District 17. I am a co-sponsor on this bill. However, I would like to state that I have gotten so many phone calls from parents on both sides of the aisle that really would like to ultimately see the entire registry just repealed. They have not gotten any value out of it, and many were really angry when they saw the bill because they had no idea that their child's data had ever been shared, let alone had they ever consented for it to be shared. And while it is said that we're HIPAA compliant and whatnot, I would like to state that part of the things that go into this registry include the last 4 digits of the patient's social security number, as well as the patient's initials, date of birth, their residence at birth, and their residence at the time of diagnosis, and their gender. Depending on which small town you're in, I know in Windham, we have a list of all of the children who were born in the year. We get a yearly town report. If you go through, we're a small enough town, and we're not really that small. You could figure out, looking at somebody's initials, who this kid potentially could be by knowing their year of birth from this report and then the year on this. So this legislation was enacted in 2006. We were the second state to put in an autism registry. West Virginia was the first. There are currently 8 states which have an autism registry in it. It was enacted to analyze the autism issue that was happening or diagnosis to see if there was more diagnoses, what could be done, and also to facilitate the planning and care for those with autism. However, when you go and ask, is anything being done with this data? What positively are we doing with this data? There's not one example. We give out a yearly report, which you can find on the HHS website, which just simply states the number that were diagnosed and the age that they were diagnosed at, and also their ethnicity. And it also gives a report by county. So I guess just aggregating and telling people how many were diagnosed with a particular disorder, I'm not sure what value that's adding. It's not providing any of the other value that it was initially stated could potentially add. So I do like the fact that now we're talking about potentially, asking parents for their permission at least to pass on this data. I guess I'm just not sure what the purpose of continuing on with something that isn't currently being used for any beneficial purpose is. So my opinion would be to be better if this was amended to just repeal the registry entirely. I'm happy to take any questions.
Thank you. Any questions? Representative Nagel?
Thank you, Mr. Chairman. Thanks for taking my question. I'm always interested in hearing about these registries that I never knew existed. And we had the ALS one last year. I diagnosed ALS. I've never even knew the registry existed. So I'm curious how many people aren't even being reported at all. The other concern that I had about this process too is having a child who does not have autism, who is diagnosed with autism, merely so we could qualify for services. I'm curious how much of this information that goes into this registry is even accurate. And I'm just curious if you have any thoughts, if that changes your mind, stimulates you to agree with what your position you just took was, or I think I just made a statement more than.
Yeah, so I'm not sure how accurate it is either. There was many of the parents, when they were upset that they found out about this, they were like, well, what if our child was diagnosed in Massachusetts? Is it going to go in there? Technically, the rule says that if you were diagnosed in Massachusetts, when you would go back to your pediatrician here in New Hampshire, your pediatrician should be putting it in there. How often that they're actually doing it, Who knows if somebody is later found out that this was a misdiagnosis, are they removing it? Who knows? I couldn't find a report on here to remove somebody. I could find the part where you input somebody, but there was nothing on the website to remove somebody if, say, you put in a person that was later found out to not have it. So I would share the same concerns as you, that I'm not sure that it's even that accurate.
Other questions? Representative Seth King.
Thank you, Mr. Chair. Thank you for taking questions. It sounds like there are some negative consequences of having been put on this registry. Can you explain that a little bit more in detail? I'm just curious if somebody could be, I don't know, denied access to some rights that are, standard for everybody else because they're on this list. Can you go into that at all? Thanks.
So I'm not sure that I'm aware of, most of the people that I talked with weren't even aware that their child was on such a list. So I have not been made aware of anybody that was discriminated against as a result of being on this list. However, I think that there is an issue of a privacy concern here, and you don't know what somebody's going to do with this data. I mean, we have data breaches with different things all the time. So could there potentially be at some point? Absolutely, especially when you consider that you're putting the last 4 digits of somebody's social security number and their date of birth. I think it makes it pretty easy, if the right person stole that data, for them to be able to find the person and do whatever they want with it.
Other questions? Representative Tellez.
Thank you for taking my question. On line 6 and 7, part of the purpose is to facilitate planning for services to children and their families. And so are you familiar, or can you describe what kinds of services children and their families receive?
Sure, thank you for the question. So I did ask the question in terms of what is being done for this planning, how is this being used? And what I was told was, in the beginning, they were trying to impress upon the fact that early diagnosis and early intervention led to much higher success. However, that's already been implemented. It's already part of regular pediatric screenings. So in terms of planning for facilitating things, this information, like the parent's address and stuff, is not in the database. So you don't have HHS coming forward and sending the parents information and saying, hey, here's these resources that are available, just so you know, like you can go and see if the child's, under 3, if they're eligible for early intervention, or if they're over 3, that they may be eligible for an IEP at school. That's not happening. So it doesn't seem like any of this actual planning, I'm not even sure how it even could happen, since it's de-identified, supposed to be de-identified data.
Follow up.
So do you know who that information is going to? Because I would assume, and I could be completely wrong, that it is family-centered early supports and services, the people who, administer the programming, or is it somewhere else? Like, it's not like it's on the web for anybody to access. It's a specific place that collects the data for planning purposes so that children and families can be served. So since you've looked into it, I was hoping you could share.
Yes, so there is on here, like, who, hold on 1 second, I'm trying to see if I can find it.
Sure,
Do we have a card from the department?
we do. Attorney Williams
So
and Attorney
perhaps that would be the
Namath
best
coming up next.
Yeah, so it
source
does,
of
it does
what
say
uses.
it is shared with the Department of Ed office, the New Hampshire Behavioral Developmental Services, the Bureau of Family Centered Services, and the Bureau of Behavioral Health. And annual results are also published on the website. So those bureaus are getting it, but I'm not sure how that's helping to provide services to kids, since these services are often provided by area agencies or schools.
Representative Shapiro.
Thank you, Mr. Chairman. DSM diagnoses are not static. They're changing all the time, and they come out with new editions of the DSM frequently. So what was considered a diagnosis of autism 30 years ago is not what's considered diagnosis of autism spectrum disorder currently. So I'm wondering if you know in the autism spectrum, in the autism registry, how the changing criteria for diagnoses is taken into account. Like, who are you supposed to report?
Thank you for the question. So I'm not sure how you're supposed to report a change, but currently there are 5 different categories under the ICD code for it. So there's childhood autism, atypical autism, Asperger's, PPD / unspecified, and other PDD. So I'm not sure how I could not find a mechanism on the website to either amend data or remove data. As I mentioned, if you later find out that somebody doesn't actually have autism, I couldn't find a way to remove that data. And possibly it exists, but it wasn't easily found on the website.
Follow up?
Oh, I think you did answer my question, that at any given time, like currently, there are specific categories that are reportable to the registry.
Correct.
Okay, thank you.
Representative Kofal.
Thank you, Mr. Chairman, and thank you for taking my question. On the FAQ on the website, there is an FAQ. This is the DHHS website about the autism spectrum registry. There is a question: what is the purpose? I apologize, I left the page. Have to come back, but essentially it says that there are several reasons to have this, but that the primary reason is to improve, is to make sure that we're screening and diagnosing autism thoroughly and accurately throughout the state. This was passed in 2006. In your opinion, has this screening and diagnosis of autism improved or become more standard as part of the pediatric care process since 2006?
Thank you for the question. So I would say that definitely the screenings that are going on in the pediatric offices have increased the number of questionnaires that they're asking at the different developmental stages to try and screen for things like this. So I would say that it has much improved, yes. But I'm not sure that that's a result of this registry, because that's something that's more standardized through the American Academy of Pediatrics.
Other questions? Seeing none? Thank you.
Thank you.
Also signed up to speak are Attorney John Williams and Attorney Melissa Namath from the Department of Health and Human Services.
Good afternoon, members of the Health, Human Services, Elderly Affairs Committee. For the record, I am John Williams. I am the Director of Legislative Affairs, and with me is...
Good afternoon, Mr. Chairman and members of the committee. My name is Melissa Nemeth, also from the Department of Health and Human Services.
And what I'd like to do is take a three-prong approach. One, to explain the bill on its face, to give you some information around the bill. Number two would be some thoughts and impressions about the discussions that have happened and options for this committee to take. And number three, just recognizing in the audience the prime sponsor for the underlying bill that created the registry, former Representative John DeJoy, is actually in the room and has submitted a pink card and will be able to provide you with some, I'm sure, robust history going back to 2006 and the development as to where we are currently. The department did submit its fiscal analysis to the Legislative Budget Assistance Office on January 4th. It was just right after New Year's, and you folks were getting ready for a wonderful session. Because they're just so overwhelmed with the amount of work, they weren't able to turn around the fiscal analysis for your consideration. I would represent to you that the bill under the four corners of the document would not represent, at least to the department, any change. We would certainly be able to make these changes, we believe, with current and existing resources. However, there could be an impact to the provider community because currently there's an additional requirement that they otherwise wouldn't have. From a technical standpoint, and again, I'm just working off the bill in case you do decide to move forward with the bill as it was presented to you and as introduced, one of the concerns that was raised in the fiscal analysis that we wanted to bring to your attention and also the sponsor and co-sponsor's attention is on line 9 and 10 of the bill when it discusses about the property of the department to include also not only the data, which is under current law, but also as to the software used to store such data. If we were to contract out on that piece, we would probably find it very difficult that a vendor would want to assign that property interest to the department. And I would represent to you right now that we're currently not working with a third party, which was a very good question raised by the committee. So that would be a concern with that section in terms of hampering our ability if we were to contract out. Currently, this is all being done in-house within the department and utilizing primarily the Excel. It does go back to 2006, so we utilize those tools that are out there and currently utilize that same, but I'm sure like everything evolving that will do exactly what I think that Representative Seth King was referring to. The other item is on line 23 under the paragraph 3 of the current law. There's a provision that adds in accordance with the New Hampshire State Constitution's guarantee of privacy. We do not take exception to that, but we would like added if the bill is to go forward to include or any other provisions of law, because that's really important to include that as well if you're going to qualify specifically where the source for protecting the confidentiality of the information comes from. This may surprise you. We actually came to a very similar conclusion as the sponsor and co-sponsor about the viability and the need for the registry. It is very, very important that we care very much about all of New Hampshire's population, but particularly those who have been diagnosed with autism. And through our Bureau of Long-Term Supports and Bureau of Developmental Services, we do contract with area agencies to provide those services. And under the definitions to qualify for those services for disability services, autism is one of those areas. So we actually believe constructively that much of what this bill was trying to, much of what the registry rather is trying to accomplish is actually happening in real-time practice in terms of identifying children who have been diagnosed with autism and providing them with those all-important services for developmental services. The other thing is, the question
You could
is...
start wrapping up.
Yes, I will wrap up,
Okay.
importantly. So the Department of Ed maintains statistical data on autism. We need to, and I would suggest that through working with your committee researcher, working with the Department of Ed, to explore what they're currently already reporting. So if you go to the Department of Education's website, under special education, they provide data as it relates to autism. It likely is either coming from the individual education plans, the IEPs, or from data that's coming from the school sources. So you are getting that all-important data perhaps from another location. So it raises a question about duplication of efforts, and thank you for your indulgence, because I really think this is an important point for you to make some progress on this legislation, is that it is probably likely that this has actually outlived its usefulness for a very different reason than perhaps because we do safeguard information. We feel very strongly about that, but it doesn't serve you well to having two sources of data and information on the same subject matter, and we would agree to explore the issue of either repealing or abolishing this might make some sense. So whether you put this bill into interim study or allow a couple of weeks to hold on this before executing out for perhaps an amendment so that you can further explore what the Department of Ed does provide for data around autism, because we certainly support the services through those diagnoses. So at least we're accomplishing that all important end of it. So at the end of the day, hopefully I didn't surprise you so much by saying we agreed for very different purposes. I have to go on the record with the sponsor and the co-sponsor for the bill, and wanted to thank them for bringing these issues before this committee.
Representative Seth King.
A procedural question for the chair. If we were to put an amendment to scrap the registry altogether, would that be considered germane, and would we be able to do that without another public hearing, or would there need to be another public hearing?
With the germane amendment, you don't need a public hearing.
Don't need to hear about. And to follow up on that question, would it be fair to put forward an amendment like that and then not allow anybody from the community to come and speak on it? Because right now, we got a public hearing that's fairly benign, but if we were to put something forth like scrapping it, nobody from the public would be able to come and defend the program, so to speak. So I'm just curious what your thoughts, and I would like to know what Representative Weber's thoughts on that would be as well.
Representative Weber.
Having seen any number of times when a committee has taken a bill on a particular subject and changed it to exactly 180 degrees opposite of what the prime sponsor intended, I would agree that it's a germane issue. And I will remind people that at a minimum, if that's the route that the committee decided to take, there is a whole new set of hearings in the body which must not be named. So people who suddenly said, "You did what?" would have a significant and real opportunity to go and say, "This is why you shouldn't." And the other body would be telling us about that. So I would be comfortable without another public hearing, but it's a good point to raise.
Any other questions? Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. I just have a question. How much does it cost to maintain this registry?
That is a question we will have to take back. I don't know. I was not prepared for that question. I'm sorry.
But to give you the idea, we are talking about getting the information from the various provider communities and putting it on an Excel spreadsheet. So it's not an overly, I mean, we meet the letter of the law, but it's not an overly robust, what you would think in terms of significant cost associated with if you were to repeal it. So there would not be a very large sum of money. We would love to think that we could utilize in other places, but I don't think that would be the case.
And because it's on the department, it goes on the department's website. It goes to the department maintains it all. It's not through any third party vendor. I don't know that there actually is a way to determine a cost. We can certainly look into that, but because it's something that the department operates on its own systems already, I don't know that we could identify a specific cost.
But what I could say to the chair is that if this bill were to be hypothetically amended to include a repeal and the full body did vote on that, then the department would be required to providing a financial analysis specifically in the four corners of the repeal and what those costs might be in terms of cost savings.
Other questions? Seeing none, thank you.
Thank you very much.
Also signed up to speak is Chase Eagleson from NHCDD. And you've asked for 2 minutes.
Thank you, Chair McDonald. Thank you for taking my testimony. My name is Chase Siegelson. I am the Policy and Planning Coordinator for the New Hampshire Council on Developmental Disabilities. We are a federally funded state agency mandated by the Americans with Disabilities Act. So I'm going to start with my stance on the bill as is, because that's what we wrote testimony for. We have testimony going around from our Director of Policy and Planning. As is, we like the bill. We like it better with Representative Gallagher's amendment to allow parents to opt out. I can't, as for now, take a stance on repealing the bill because we haven't looked into that enough. But if it's defunct, as the attorney said it might be, then it's defunct, and there's no point in getting the same source of information from two different places. I'll try to be short and sweet, so that's all I have for you.
Oh, okay. Any questions? Seeing none, thank you. Also signed up to speak is Jessica Goff. And you've asked for 3 minutes.
I will also try to be brief. Good morning. My name is Jessica Goff, and I'm here today speaking as a member of the public. I am also in support of HB 1615 with the conversation of getting rid of the registry altogether. I would also back that. Actually would back even more so. This bill, I think, is a step in the right direction to ensure that folks who are diagnosed with autism do have the right to privacy in the state. We know that historically folks with disabilities have been mistreated by a variety of governmental bodies, and there's a warranted fear in the community of getting assessed. I know in this original bill, it did seem like the intent was to track youth, but there are a number of adults I know in the community who are avoiding seeking diagnosis because they, as an adult, don't want to be added to the registry. I will say that in New Hampshire, it's my understanding that there are not any autism-specific resources for adults. They are included through the area agencies, and so it would be my understanding that other sources of data would be just as helpful. It's also important to note that the current registry doesn't involve consent. I know that HIPAA doesn't necessarily cover the government. But again, I would say autism in this way is being treated as different than any other diagnosis for some reason. If someone's diagnosed with schizophrenia, they're not added to a registry. If someone's diagnosed with ADHD, they're not added to a registry. It's just autism. And that really plays into, I think, a fear, especially that was happening in the early 2000s around autism being an epidemic of some sort that needed to be tracked specially. And I think we've come a long way in realizing that it is another developmental disability. It isn't an epidemic or something that needs to be a fear. And so I will say with the current registry, they are tracking more information than is required in the bill, specifically in the area of your social security number. And again, it's a small state. So in New Hampshire, if someone gained access to that information, it would be really easily identifiable. Again, last four of your social, your phone number, your birthday, that enough in New Hampshire is that. I'm happy to hear that the DHHS does keep that information in-house. I know a source of concern was any third parties that might have access to that information. So I was glad to learn that. Again, I am definitely behind getting rid of the registry completely, but I think this bill, even as is, would be able to get us in the right direction. We know that autism isn't necessarily a problem, it's a phenomenon, and people with autism do deserve equal protection under the law. And that's what I have. Thank you.
Thank you. Any questions? Seeing none, thank you.
Awesome. Thank you.
Also signed up to speak is Don DeJoy. You don't indicate how much time you need, but 3 minutes would be perfect for us.
Thank you, Mr. Chair. Members of the committee, for the record, my name is John DeJoy. I am a lobbyist, but I'm here representing myself, specifically as the prime sponsor of House Bill 1709 in 2006. There have been a number of questions about why this bill came forward, what the use of this bill is it still useful? I'd like to explain a little bit about that and then try to answer questions. I didn't never expect it 18 years later to be talking about this bill again, nor did I expect one of my students from UNH to be testifying before me. So this truly is a New Hampshire moment. So when this bill was filed, it was filed for the Autism Society of New Hampshire. It was a group. It was a parents group who's represented their children who were dealing with autism and were trying to expand services for the autism for folks affected with autism. It was not contemplated at that point that autism was an adult disease. It was contemplated in 2006 as a childhood disease. It was also contemplated as having any number of nefarious reasons for its cause. If you remember back to 2006, one of the primary theories was that mercury in vaccines is what was causing autism. That was the intent of this bill. It was never to provide services to individuals. It was to permit the department to gather data so that the department could see any growth in the number of people affected with autism to be able to prepare services writ large to provide what was needed for the community. The other piece of this was that it was hoped that this data would be available to researchers. You know, the issue with data is once it goes by, you can't go backwards and collect data very easily. So the idea at this in 2006 was to collect as much data as we could to permit researchers to have a robust understanding, hopefully of the cause of autism, clearly of the manifestations of the condition, but hopefully ultimately the cause. I understand we still do not have a cause today for autism. Maybe there isn't one that we can easily identify. But I think the data is as important today as it was 18 years ago. This committee, took great pains to protect confidentiality. not only because it was the right thing to do, but because there was a room full of parents whose children had autism. The parents knew their children would be on this registry, and they wanted to make sure that their children and any other children would be protected from disclosure. I'm comfortable that we did a pretty good job back then. I think the bill before you suggests that there's ways that it can be improved, and that's great. But GELCAR had to approve all the rulemaking. And so I'm comfortable that GELCAR complied with the statute in terms of how far the department could go in making rules. To Mr. Williams' point that DOE may have this data as well as DHHS, what I said to him before the meeting is, I don't have a vested interest in where this data is tracked. What I have a vested interest in is that this data is tracked anonymously, fully anonymously, and that it's available for researchers that hopefully will continue to work on a greater understanding of autism as well as how best to treat it.
Please start wrapping up.
With that, I think I can just end my comments, and I'd be happy to answer any questions.
Thank you. Representative Shapiro.
Thank you, Mr. Chairman. This is a curious situation where so 18 years ago we had parents and advocates for people with autism coming to ask for this, and now we're having the people who spoke, but they also referred to people calling them and getting calls about advocates and maybe parents of people saying we want to get rid of this. So what would you say that says about the evolution of our understanding of autism and the acceptance of that as a diagnosis, and how far we've come in terms of providing services for these things?
Thank you for the question. I think what I would say is that the information that was presented is anecdotal. So we don't know if it's one person or dozens of people. I think to the extent, I think we have evolved in our understanding and acceptance and treatment of autism. I think one of the reasons we've evolved, and I don't know, I mean, there's no evidence that this registry caused some of the understanding, but certainly the registry is correlated with a greater appreciation and public acknowledgement of autism. I think if it would be unfortunate, just like it would be unfortunate if we chose to abolish the cancer registry, or we chose to abolish any registry. I think the data is vital, and we cannot go back easily to recreate the data. I do think we have to go to great pains to protect people's anonymity, as we would in any scientific inquiry. I don't know that opting out of the registry or removing your name at 18 benefits the scientific inquiry. But I think assuring the confidentiality certainly does.
Other questions? Representative Merchant.
Thank you, Mr. Chairman. Also, thank you for taking the question. We heard earlier, at least I did anyways, that there's data that's apparently available publicly that doesn't ensure confidentiality. So I'm not sure how the rules are written that got through GELCAR, but that is definitely a concern. Can you speak to that? Because going back to it, if the goal was confidentiality to remain anonymous, but there's data on the website that can drill down to someone's level of detail, that sort of doesn't remain confidential.
I can't speak to the data that's presented now. I haven't looked at it recently. I can speak to what I heard before, which may have been a little different than what you heard. And I don't know what is more accurate. What I heard is that two different things were being conflated. That there is data available that should be in aggregate, not in specific. The other piece was that people at the same time were talking about the information that is provided by pediatricians on the registry form, which would include other information. Now, the Social Security number, to the best of my knowledge, was never specified as a data field to be collected. It was always intended to be a fully, to be a unique ID that could not be tracked back to the individual. That was the intent.
Other questions? Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. You brought up a very interesting point about the 18-year-old thing, and that really troubled me a lot. I mean, if we want to collect data, we really want to know how autism is affecting people over the entire scope of life, not just before they turn 18. And I'm just curious what your thoughts are about that addition to this, or amendment to this bill.
I have that as well as gender circled as things that should remain in the registry to the extent that the registry remains. I think both of those pieces of information should remain. You know, I think data is important. Data is how we've learned. I mean, you're a doctor. Data is how we've learned about disease and how we've eradicated disease, how we've dealt with epidemics in the past. This was an epidemic in 2006. This was an epidemic of our boys who were disproportionately diagnosed with autism. People didn't understand why, didn't know where it came from, didn't know how to fix it. And at that point, we're talking about fixing it. I don't know what's happened with the data as far as research, but I think it's still as vital today as it was 18 years ago.
Representative Weber.
Would you agree with me that the concern with data is when you start self-selecting in one way or another, the data becomes much less useful in the aggregate to give us a clear picture of what's going on out there, so that once you start allowing people, as I think we should, to choose whether their data goes in, whether their data stays, and all of that, does that not make the data by definition less useful as data than it would be if we were fully reporting?
Thank you for the question, Representative. It does. And in fact, in research, it makes it frankly misleading, because researchers will come to findings that they will believe to be accurate, but because of the data set, they would be wholly inaccurate.
Other questions? Seeing no other questions, thank you. Okay, I have no other pink cards. No one else has signed up to speak on HB 1615 FN. 2 people did sign the blue sheet in the back in support of the bill. Online, 9 have indicated they support it, and 2 indicate they oppose it. So I'm going to close the public hearing on HB 1615 FN. I'm going to open the public hearing on HB 1482. And at this time, I'll recognize the prime sponsor, Representative Gerhard.
Thank you, members of the committee. Representative Jason Gerhard, representing Franklin Northfield, Merrimack 25. I understand you guys are only an hour and 15 minutes behind schedule, so I'll move quickly. This bill would allow for the sale of blood and organs in the state of New Hampshire without government interference. Currently, we are allowed to sell plasma, sperm, eggs, hair, breast milk, bone marrow, stool, rent space on your skin via tattoos or other advertising, participate in clinical trials, which might just turn out to be deadly. You can rent your womb as well. I would like to just read just some excerpts from an article that a supporter wrote in favor of this legislation that I think is interesting and highlights some topics that may not be immediately apparent. There is a perpetual chronic blood shortage. Since I'm an O negative blood type, universal blood donor, and cytomegalovirus negative, a disease that most adults have been exposed to but is fatal if babies are exposed to it, I am constantly bombarded with emails from the Red Cross soliciting my blood. Fortunately, I donate my blood as often as they allow me to, but not everyone is like me. In fact, most people are not. According to the Red Cross, only 3% of eligible people donate blood, and only 7% of people are O negative, with a guarantee that most of these people do not donate and are likely not cytomegalovirus negative. As a result, there's a coin toss whether or not a newborn will obtain life-saving treatment, since there is not enough time to test a newborn's blood type ahead of time. How do we solve this? The best way is to provide additional incentives for eligible people to be able to donate their blood. Imagine if we can only eat food from farmers that donated their time and labor to produce it. That is the situation we are now in with blood. By allowing people to be compensated for donating their blood, we could readily increase the supply, especially if people are paid more given their blood type or eligibility. Imagine what parents would pay to have their child's life saved instead of having to exclusively rely on donations, which are severely insufficient. Also, do not expect purchasing blood in this instance to be prohibitively expensive. With minimal government barriers to entry, many people will donate, which will substantially increase the supply and allow for a reasonable market price for blood. Americans are already allowed to sell their blood, plasma, and sperm, so there's no reason they should not be allowed to sell their whole blood and or other blood products for money. While some may argue there are ethical implications with being able to legally sell your blood and or organs, I assert that the real ethical violations are manifested when the government imposes barriers against being able to do this. Not only does it make organs and blood less available to people that are in chronic need of them, it also implies that other people own your blood and your organs, since they are allowed to tell you what you can and cannot do with them. This is a form of tacit slavery that should not be allowed to persist in the 21st century. If you value freedom or would like to improve the survival of babies and chronically ill people, you agree that it is time to end this prohibition on being able to do what you want with your own body to help others with an added incentive. And I'd just like to add that in 2017, The Hill ran an article where they discussed that the Orange County District Attorney's Office in Southern California prosecuted Planned Parenthood business partners DaVinci Biosciences and DV Biologics, who signed a $7.8 million settlement in which they were banned from doing business in the state of California ever again, admitted to breaking state and federal laws by selling aborted fetal organs and tissues from Planned Parenthood for profit. So organs are already being sold. That's not a question. The question is who is benefiting from it, and it's not the people who actually own those organs. So that's where this comes down to. And the last thing is the New Hampshire End of Life Options Act, HB 1283, was recently introduced, and this is the medical aid in dying. It's allowed in 10 states and the District of Columbia. So you're allowed to, and it's being proposed to do it in New Hampshire, you're allowed to kill yourself, but you can't sell your kidney. I think we got to go back to the old adage, my body, my choice, and you should be able to do what you wish with your body, since it's your body and the government does not own your body. So that's all I have to say, and if anybody has any questions, I'd be interested in answering them. If I can.
Representative Seth King.
Thank you, Mr. Chair. And thank you, Representative, for taking questions. I'm with you 100% on the whole being able to do this sort of thing. There's a book I think that came out a while ago called When Altruism Isn't Enough. It's been a long time. I never read the book, and I'm not sure if I'm even right on that. But basically the idea is that there's a lot of people that could really benefit from this that are dying every day. And there are people that could benefit from selling an extra kidney that they, they're not inclined to go give it away and go through the procedure and all that. But for a healthy price, they probably would. And that could benefit a lot of people, both parties. But I'd like you to talk a little bit about your bill, because while you made the case for the philosophy, you didn't speak on the bill too much. One of the things I like to do, at least in my world, is when I see a problem the government has created, I like to find those lines of code and just delete them, as opposed to making new lines of code. And what I see here is, it looks like there's new lines of code being added here, 359-V:1. Why don't you find the lines of code that prohibit the selling of blood and have them erased, as opposed to making a new section here? And then also on part 2, I'm just a little confused why, section C, we're talking about testing of cannabis, therapeutic, and then all of a sudden it's talking about blood and organs. I don't know. I'm just curious why those two are together like that, and couldn't couldn't we just scrap lines of code as opposed to making new ones? Thank you.
Sure. The simple answer is I'm a carpenter, so I actually trust in OLS, which is many times that goes south. So this bill is in your hands in the committee, and that's actually a really good point. Don't add, simply take away. So I'm totally on board with that. However you guys wish to make this happen, that would be awesome. That's all I'll say on that.
Other questions? Seeing no other questions? Thank you.
Thank you.
Also signed up to speak is Alex Glazier from the New England Donor Services. And you've asked for 4 minutes. I'll try to keep it to 3 if you could, please.
Yes, absolutely. Thank you. Good afternoon. I'm Alex Glazier. I'm the president and CEO of New England Donor Services. We are the federally designated nonprofit organ procurement organization responsible for coordinating organ and tissue donation for transplant in New England and New Hampshire. And we oppose House Bill 1482. I'm going to just pick out 4 points. Number 1, the system of transplant is designed to maximize life-saving transplant and ensure safety. Each donated organ is medically evaluated for transplant, and this includes extensive medical evaluation, the donor's history, diagnostic imaging, serology testing, you notice the lab provision there, to identify infectious disease, blood and tissue typing, to ensure that the organ transplant will be safe for the recipient and also in the case of living donation for the donor. So organs that are from deceased donors are then determined medically suitable for transplant. If they are, they're offered to waiting patients that are a biological match, another key part of the national oversight here, through the transplant surgeon, according to the National Transplant Wait List by the Organ Procurement Transplant Network, and this is operated by the U.S. Health and Human Services. This is a well-regulated system. It continues to grow transplantation, which is important for you to know. Nationally, 2023 was the 13th consecutive year in a row for donation and transplant increases here in New England and in New Hampshire. New records were set last year for organ donation and transplant, 52% increase from 2022. So this is not a static system. It is a dynamic one that continues to grow. The second reason is that this bill would compromise transplant patient safety. This bill would open the doors literally in New Hampshire for unregulated private sale of organs between individuals from anywhere, nationally or internationally. There's nothing in here that would prevent individuals coming in to sell their organs or individuals coming in to buy organs. This kind of rules-free market for deceased and living organs would create substantial medical risks both for living donors and for transplant recipients that would not be subject to the extensive medical screening I just already mentioned. It's not even clear if these bought and paid organs would be subject to the criteria mentioned for health and safety, or even that they would need to be performed, these transplants would need to be performed by a licensed physician. Number 3, unregulated organ markets are unethical. And one thing to point out here that unlike blood or semen or human milk, organs do not regenerate. So when we're talking about kidneys primarily are what are donated, and living donors that donate their kidney do not grow back an additional kidney. This is very different, and it should be treated differently in policy. There's a real potential for physical exploitation of vulnerable individuals who could be coerced into selling their body parts for financial gain. This could create a perverse market system where body parts of the poor become commodities for the rich to gain preferential access to life-saving transplant. The market price, completely unregulated, would look pretty different for someone who is destitute than someone who has a well-paying job, who might not be incentivized by the same dollar amount. So this unethical confluence of pressures could literally make New Hampshire the international epicenter of human organ trafficking. And I say that because there are no states in the US and only one nation in the world that has laws that allow for the buying and selling of organs, and that nation is Iran. It has a regulated, not an unregulated market, and there are widespread reports of coercion in Iran, both for the donor being coerced into selling and also the recipient, where the recipients are sometimes held hostage right before the transplant surgery, where the donor then demands a higher dollar amount in order to go to the OR. So the fourth and last point I have is that this is preempted by federal law and current New Hampshire law. So the United States Congress and New Hampshire have already determined that private commercial markets don't serve the interest of donors or recipients. The National Organ Transplant Act specifically and clearly prohibits the buying and selling of organs and would preempt HB 1482. And New Hampshire's own state law at Chapter 291A, which codifies the Uniform Anatomical Gift Act, which is a uniform state law that's been passed in every state in the country, also forbids sales and makes it a felony. So in conclusion, the process of organ donation is really medically complex. It involves numerous well-regulated institutions working in concert with trained professionals. It has to be accomplished in critically short timeframes, and that the organs that are donated need to be recovered and transplanted quickly from medically suitable donors in order for life-saving transplant to be successful. Our system is founded on ethical principles to ensure voluntary participation in donation, and these frameworks have served to make our system medically safe, ethical, efficient, but importantly also constantly improving for the patients in need. I'm happy to take any questions.
Representative Shapiro.
Yes, thank you, Mr. Chairman, and thank you for taking this question. Could you get to us a link to the federal laws that preempt this kind of law?
Absolutely.
And follow up?
Follow up.
You spoke about organs, which is your purview, obviously, but do you have anything to say about the other part of the bill that would include blood and blood products?
I would just say that unregulated markets are unprecedented in the medical community, and there are important health and safety regulations that need to be considered.
Other questions? Seeing none, thank you.
Thank you.
Also signed up to speak is Zephyr Wood. And you've asked for 2 minutes.
Thank you, members of the committee, for giving me your time and for being here on Valentine's Day. I appreciate it. So this is an issue that's really important to me. I do like taking part of the political process here in New Hampshire, but there aren't many bills that have affected me personally or friends that I have personally. I'd say that this is one of the only ones. So I decided today that I would tell you a story about my friend. His name was Daniel. He was diagnosed as suffering from diabetes, and he was able to survive with it for quite a while. He received treatment, but he was on the donor list for ages because there weren't any donor matches for him. And if you look at the kidney registry, it's really long, and there's a lot of people waiting for it. And unfortunately, when COVID happened, the medical system was pressured, and it put those pressures on not just the supply of kidneys, but also on the amount of medical professionals that would be able to facilitate these operations. So the list got longer and longer, and then they changed the requirements to make it so that if you weren't vaccinated for COVID, you would automatically be taken off the list. This was Daniel was a person who had very strict religious beliefs about vaccines. He didn't want to put his health further in jeopardy than it already was, so he opted out of it and was removed from the list. He thought about maybe going out of the country to see if he could, purchase a kidney because his life was in jeopardy, but he realized that the moral and legal implications of that would be too much for him. He didn't want to, do a shady market deal where he's trying to get somebody's kidney, even if he thought like, okay, this person's a totally willing participant. He just didn't feel morally comfortable doing that. And so unfortunately he passed away.
He was somebody that loved to do poetry. He was loved by members of his community. He had a family. He didn't have a lot of money, so the community actually crowdfunded a wonderful funeral service for him. And I think that if this bill or a variation of it, I mean, you're the committee members, if you want to change it to make it more in line to something that's regulated or removing lines of code, I think that that would be fair. But I believe that if there was a framework in place for a willing participant like me, for example, to have given him my kidney for compensation like that, I think he'd probably still be alive today. And I know that there are lots of examples of people like this. It's not just Daniel. There's tons of people that are affected by diabetes, and kidneys are just one example. Like the state rep mentioned, there's people that are in chronic need of blood as well. And I think that we shouldn't put barriers between someone being compensated to save a life. I think that that's what it comes down to. I'm willing to take any questions.
Any questions? Representative Leon.
Thank you, Mr. Chairman, and thank you for being here. And I'm so sorry for the loss of your friend. We had passed a bill previously about not discriminating about vaccine status for healthcare. Would you mind sharing when your friend was removed from the registry?
Yeah, it was a couple years ago. I'd say that it was maybe like about a year after the vaccines were rolled out. If you want, I emailed everybody on the committee, including you. So if you want, I could reach out to you later and provide you an exact date that he was denied.
I would appreciate that because
yeah.
it seems that sometimes we pass laws that don't actually have an impact.
Yeah.
So it would be unfortunate if he simply was not within the time frame, but it would be an even more of a travesty if he should have been protected and he wasn't.
Yeah,
So
I mean,
thank you.
and he did live in New Hampshire. He lived in Manchester, so I think that he would be protected by this if it was in effect at the time.
Sorry.
Other questions? Seeing none, thank you.
Thank you.
Also signed up to speak is Peter Moran from New Hampshire Funeral Directors Association. And you've asked for 5 minutes, sir. If you could keep it to 3, that'd be great.
I will do my best to make it shorter. Thank you. Thank you, Chairman McDonald, and thank you, members of the committee. You've all been here way too long. I appreciate your service and your patience. Yes, I'm Peter Moran. I'm here representing as the executive director representing the New Hampshire Funeral Directors Association. Some of you have seen me before. And I'm also a licensed funeral director and embalmer here in New Hampshire. I'm here before you today in opposition to this bill. There's various things that raised concerns when I first read this. My first concern was why and, what's the purpose. The sponsor addressed that. But of course, I always kind of look at the big picture and as to what could go wrong. And this is kind of a very broad interpretation of this bill. I respect his position and his so far. I'm a believer in personal freedom and those things. Our concern is of public health and welfare. And also ethical issues of handling and the disposition of these body parts and fluids. The representative from the New Hampshire Organ Bank, who we work very closely with in funeral service in terms of donors. When it comes to organs, no, those are done in the OR in the hospital. But when it comes to other tissues and other tissues and corneas, those things are often harvested or retrieved in the funeral home. And I also have to point out that in my anatomical education in mortuary school is that skin is the largest organ in the body. Okay, so if we're talking organs, we're talking skin. And of course, they do that for tissue donors, for burn victims, and in other cases like that. And, we have people, what we've had in the country in the last several years, not so much in the Northeast, but we're seeing it more and more across the country, particularly in the Southwest, is we have basically unlicensed third-party providers who are offering on billboards free cremation if you donate your loved one's body. for medical science. What happens in these cases, and this I won't get too graphic, is the family comes, they're bereaved, but they may not have that $500 or $1,000 or more that they would need for that cremation. This is a very attractive offer. And so they sign documents that they have no idea they're signing. And basically what they're doing is they're turning their loved one's body over to these individuals who then take that body and, quite frankly, part it out. And it is used, yes, for medical research and other things. It's been in some cases where they have been used for ballistic tests with the military, and other instances like that. And what happens is the parts are either sold or leased, and they can be leased over and over again or resold. There is no ability of tracking this at all. And eventually, the parts never come back to the family. I'm not sure what they're given in return as far as cremated remains. But the fact that they're told that that's what they'll receive is blatantly false. What we're doing right now currently on a national level, we're involved very closely with the National Funeral Directors Association, as are all of the other state funeral associations. We've been working on this bill, and I'll just read it. I won't read the bill, but the title of the bill, and I will send you give this information in my testimony here, which I have a copy for each of you. It's both in the Senate and the House, and this is the Consensual Donation and Research Integrity Act of 2023. This is the third Congress that we've introduced this. We're gaining traction. It's getting more appeal. Most of the times when I meet our members here in New Hampshire are all supporting this in both of their houses. And of course, we'll be able to monitor that under federal regulations, particularly when it comes to interstate commerce. That's the one place that they can do it. And so we've got to find a way to rein this in. There are people who are totally unscrupulous, and I'm not saying that that's the case here, but there's that possibility. We open it up, and it's the kind of thing that keeps me awake at night. Because, we deal with the families who are going to be dealing with these people or in these situations when things don't work out. And I respect what the representative from the Oregon Bank made about the idea of individuals perhaps being coerced. We're concerned about the deceased, their human remains, because this bill doesn't specify, is it the living or the dead, and who sells these parts. And families nowadays, if they felt they could, I'm not saying they're all like this, but there are those who could just see the dollar value in their loved one, what they might be able to get if they could sell body parts.
You could start wrapping up, please.
Yes, sir. I'll close it right up now. And of course, more recently, we just had last year, very close to home, the instance with the Harvard Medical School, their morgue, and the manager of their morgue had been selling body parts around the country. It was found out that this happened, at least involved 8 bodies anyway. I think this has been going for much longer. The courts just dismissed the civil cases against Harvard and their other people. This individual is still under federal indictment, again, under the interstate commerce part because he was selling them across state lines. This gentleman, unfortunately for us, is a resident of New Hampshire. And so, we that's not how we want to make the national news. And but he is still under investigation. He's still being tried for that. So this problem is closer to home. But I just think we need to regulate this and make sure there's a lot more work that needs to go into this if we're going to do this. And I have to certainly bow to the medical individuals and the doctors and so forth in this.
Thank you.
Thank you.
Are
there any questions?
Seeing no questions, thank you. No one else has signed up to speak on this bill. 5 people did sign up on the blue sheet in the back, 1 indicating they were in favor, 4 people indicating they were opposed. Online, last time we checked, and 19 signed up in support, 16 signed up in opposition. That is the last bill for us to consider today, so I'm going to close the public hearing on HB 1482. We'll be reconvening tomorrow morning for additional hearings at 10 a.m. Thank you all for being here, and we stand adjourned.